everybody. We're super glad that you came to join us this morning. It's probably time for us to get started because the event's just going to go on and on. So if you'll come in and take a seat, there's snacks and coffee and water and tea, and the bathrooms are in the back if you need anything. But the four of us wanted to just introduce ourselves real quick and tell you a little bit about what we do. Just who you are.
Okay.
You got it.
I'm Dr. Bajaj, and I'm a plastic surgeon in Oklahoma City. And I think part of what we wanted to also talk about was the history of how we came up with POWHER. And it started over just a dinner with a couple of us together, having ideas about what we can do for women's health in Oklahoma.
And I'm Stephanie Taylor, and I'm a general and breast surgeon here in the Oklahoma City area. And each one of us will kind of tell you more about ourselves as we go through our talks later in the day today. But I'm just super happy to be a part of this group of women who wants to empower women to take care of themselves.
Right, and I'm Dr. Jessica Enix. I'm a board-certified general surgeon. I was lucky enough to be in this group. When I joined Dr. Taylor, she kind of took me under her wing and introduced me to all these wonderful ladies up here. So I'm just very excited and eager to get all the education out there.
Thank you. Hello, everyone. How's everybody feeling this morning? Ready for a fun morning? I'm Dr. Pooja Singhal. I'm board-certified gastroenterologist and a hepatologist, and I own my practice, Oklahoma Gastro Health and Wellness. And we are so honored to be here today talking about POWHER. So POWHER is a brainchild of all of us. It stands for Physicians of Oklahoma for Women's Health Revolution, because it's high time that we paid attention to women's health. And one of our mission statement, core values is through education, advocacy, and innovation to empower women to take charge of their health. So we are so thrilled that you're here, and please help us spread the word. And if you have ideas for collaboration, we are open to that as well.
So we'll go ahead and get our speakers for the first session to come on up, and then we'll introduce them. And just little housekeeping things. There's restrooms in the back. Again, there's coffee, there's water bottles under the sink in the fridge, and snacks over there. We will have 3 or 4 speakers per session, and then we'll do questions. So it'll be an open format where I'll walk around, you can ask the speakers questions, and then we'll take a 10-minute break and you can regroup on. Dr. Anita Stidham, she is the director here at the Breast Center. She is a mammographer, a breast radiologist, also board-certified radiologist here in Oklahoma City. Dr. Julie Wiley is a GYN here in Oklahoma City. She's going to talk to us about cervical screening. And she's also in private practice down on the south side. So we really try to encourage women who own their own businesses and are interested in women's health to be a part of what we're doing. And then Dr. Singhal, you met her, so she is a gastroenterologist, part of Oklahoma Gastroenterology. And this panel is about screening. So the steps that you need to be taking to make sure that we catch disease early.
Okay, good morning. Thank you everybody for being here today. It's a pleasure to be back this year to talk about skin cancer screening. I noticed the flow of presentations this morning starts with the largest organ, skin, then we move on to breast, cervix, and then the anorectal area, so it's a nice progression. As most of you know, the skin is the largest organ, so not surprisingly, the most common type of cancer across all organ systems is skin cancer. So I just brought this cross-section model of the skin. I always tell my patients to picture their skin like a cake with 3 layers. The top layer is like the frosting, and that's the epidermis. And that's where we're going to focus all of our attention today, because the 3 most common skin cancers all start in the epidermis, which is at the very, very top. So does anyone know what the most common type of skin cancer is? Melanoma is one of the three most common types of skin cancer, but the most common type is called basal cell carcinoma, and it is the most common skin cancer and cancer across the board. So basal cell carcinomas start at the epidermis layer, at the base of the epidermis, at the base of the frosting layer, and it is composed of a cell called a keratinocyte. So you can picture your epidermis like a brick wall. The bricks are the keratinocytes, and those are the ones that become mutated and become cancerous. So I have a couple of pictures here of basal cell carcinomas in clinic. They can be sometimes very difficult to detect because they can be very small, very nondescript. They can look like a small pimple, but occasionally they can be very dramatic, ulcerated presentations like you see on the ear and the nose. And we rely on dermoscopy, which is the tool that I brought with me. This is a magnified lens with a bright light that helps us see the vascular structures, the pigment patterns, and this is a really important way that we can pick up basal cell carcinomas early. In the same group, here's a couple more examples of basal cell carcinomas, most often in sun-exposed surfaces, so head and neck, arms, chest, the legs also. They are not considered to be a high risk for metastasis or spread to lymph nodes, but they can be locally destructive. So basal cell carcinomas do have to be treated so that they do not invade into local structures like the nose or the eyelids or other parts. Even the legs can develop large ulcers from untreated basal cell carcinoma. I have a couple pictures here of a similar type of keratinocyte-derived cancer called squamous cell carcinoma. So again, we're just in this topmost layer of skin, and squamous cell carcinomas can be more common in men, and also sun-exposed surfaces like the back of the hands, the ears, and they tend to be very scaly. They're keratinocyte-derived, so those types of skin cancers we often see presented like this, very hypertrophic, large, scaly nodules. A lot of times patients will come in saying, I have dry patches on my face or arms and hands that don't get better with moisturizing, because those are not dry skin. Those are precancerous lesions called actinic keratoses. They're exceedingly common. 40 million people have them, and those are pre-malignant, and 10% of these can become squamous cell carcinomas. And it's important to recognize them and treat them, and a high burden of actinic keratoses often signals a higher risk of all the cancers because they are like a canary in a coal mine. If someone has a lot of them, it's a sign of lots of chronic UV exposure. So those are treated with liquid nitrogen or 5-fluorouracil, which is a chemo cream. So what are the risk factors, and how much of this pertains to you? Age over 50, many sunburns, 5 or more sunburns in your lifetime can double your risk for all the skin cancers. Tanning bed exposure is a huge risk factor. Immunosuppression, if you have received chemotherapy or you take medications for rheumatoid arthritis, anything that suppresses your immune system can increase the risk. And skin type, fair skin that tans with great difficulty and burns easily, is considered an independent risk factor. One special population is organ transplant recipients. Those patients are 100 times more likely to develop squamous cell carcinomas. So now we're going to move on to the melanoma category. So someone said melanoma earlier. This is a very important skin cancer to recognize. Also in the topmost epidermis layer, but if, again, you think about that brick wall, the bricks are the keratinocytes that give rise to basal cells and squamous cells. Melanomas come from a totally different cell type called a melanocyte, which is like a specialized pigment-producing cell. So their behavior is different, and they can be more life-threatening if they're not detected early. So I have a couple celebrities, Bob Marley, Hugh Jackman, Khloe Kardashian, and Noah O'Donnell. They've all had a melanoma, so very different demographic groups, but the case incidence is 200,000 cases a year of new cases of melanoma diagnosed. So very similar to the other risk factors, but keep in mind moles. If a person has many moles or many larger moles, their probability of having an atypical mole or a melanoma increases. So those are, I have some young patients that come in annually for skin checks because they just have a high burden of moles, and that's a risk factor for melanoma. Family history is important. A lot of times family history is a little nebulous. Patients will say, my grandmother had a melanoma, but most of the time it was probably just a basal cell or a squamous cell. It's important to recognize if it was actually a melanoma that a relative may have had before they were 50, because that's the risk factor for you. Asymmetric, border irregularity, color variation, diameter, evolving. I think the E is really important. A mole that's changing is a really strong indicator of atypia or malignancy. Ugly duckling sign. Someone has a lot of moles that are just lighter brown in color, that are larger, and then they have a 2 millimeter, 3 millimeter, really dark brown or black mole. That is your ugly duckling. So it doesn't have to be big, it can be small, but if it's small relative to the others, doesn't have a sibling or a matching pair, that's an important sign to recognize. So dermoscopy is really helpful. These are a couple melanomas in clinic with dermoscopy photos. I'm not sure how well they project, but they can be really subtle. This was on the back of the ear. It looks like a little freckle, but on dermoscopy, the network is just irregular. So it does require optical mileage, having seen a lot of moles, recognizing the ones that are irregular is critical to catching it early. This is a melanoma on the bottom of a foot in a Caucasian middle-aged female that had been there a long time. She thought it was a bruise, but it clearly had some irregular patterns. Here's some very prominent melanomas that fit all the textbook characteristics. This was a really small but very dark mole on the back of the leg. For women especially, the lower extremities, the buttocks, the legs are the most common places for melanoma. So the hard to see places like the back of your thighs, the back of the legs, are commonly where I find the melanomas. In men, the torso, their back is the most common area for melanomas to show up. And although overall skin cancer is more common in men, women are uniquely at a higher incidence or higher risk for melanomas before age 50, and tanning bed is a big risk factor for that. These are a couple more examples of melanomas, and then this is a very dramatic example of an invasive melanoma on the arm of a landscaper that was that had gone to lymph node. There's this type of melanoma that can just be on under the toenails or on the feet. That's the type of melanoma that Bob Marley had. And then melanomas, unlike basal cell and squamous cell, have a higher propensity to invade into deeper structures. So it can go beyond the epidermis into the deeper layers and possibly enter a lymphatic vessel, and then can spread to lymph nodes and to other organs like the brain, the lungs, the liver. So it is important to catch it early. This is just a brief slide about how melanomas are treated with the wide excision. If it is deeper than 0.8 millimeters, then a sentinel lymph node is obtained to see if it has spread to lymph nodes. But if a melanoma is caught early, the 5-year prognosis or survival is 99%. So with skin cancer screenings, of course we're trying to find the basal cells and the squamous cells, but really the priority is to find melanomas early because it has a huge impact on a person's survival. This is a picture showing how Mohs works. Some of you might be familiar with that technique for treatment of basal cells and squamous cells, where the surgeon is trying to remove just enough tissue to remove the skin cancer cells, but not more than that. And then I just mentioned Merkel cell in my presentation because Jimmy Buffett has brought this very rare skin cancer, but very aggressive skin cancer to light. It's usually more common in men who are older, who have had lots of UV exposure, who are immunosuppressed, but it's a very aggressive skin cancer. So this can sometimes present very subtly like a pimple that grows very quickly. It can come up like a cyst. So it's just a skin cancer to be aware of. So 3 main take-home points are prevention, sunscreen, hats, long sleeves, avoiding sunburn, avoiding any type of tan, obviously in a tanning bed, but also outside. Early detection is the key, so checking your own skin monthly, being aware of your moles and being aware of any changes is critical, and having a board-certified dermatologist do a skin check and establish a baseline and determine what frequency makes sense based on your risk factors and what we see. This is just a picture of how to do your self-skin check with a hand mirror, and this is our clinic, Spectrum Dermatology. We're in Edmond and Oklahoma City, and we have a lot of availability with new dermatologists in our practice, so please come see us. Thank you so much.
Hi everybody, I'm Dr. Anna Stidham. I go by Anita, by the way, so I have two names. So if you see Anita and Anna, it's the same person. Okay, so there's a long history behind that, but I won't go into it. So basically, I'm going to talk to you about breast cancer and breast cancer prevention. And the main prevention, of course, is screening. And so just some background here. It's the most common cancer in women besides skin cancer. Skin cancer is the most common. But 1 in 8 women will be diagnosed with breast cancer in their lifetime. It is the most common invasive cancer in women. And it's the second main cause of death after lung cancer. Lung cancer primarily because there's still a lot of people smoking out there. So the earlier diagnosis, of course, the better chance of survival. Mammography is the gold standard for finding breast cancer early. It's the only modality that has been proven to actually decrease mortality or decrease the death rate over time. So annual screening should begin at 40, and you should have it every year. There are other modalities or other types of screening methods that are available. There are ultrasound and MRI. They're complementary, but you should always have a mammogram as a baseline, and then you can add to that. Self-breast exam and clinical exam are also important because even if you have your annual screening mammograms and do everything right, you can still have a sneaky cancer that doesn't show up on imaging. And so it's very important to know your breasts and to do those self-breast exams. So for average risk women, which is most women, you start at 40 and you go every year. But there are other categories that you want to pay attention to, and you may have gotten maybe a letter in the mail saying you have dense breasts, or you may have heard that buzzword, what does that mean? And so if you have dense breasts, you kind of have to be a little bit more careful for 2 reasons. One is if you have dense breasts, that means that you have more glandular tissue, and the glands is where the cancer likes to grow. So it doesn't mean that your breast is more stiff to the touch, it just means that you have more glandular tissue within your breast. And so for that reason, you have a higher risk of breast cancer. Also, when you have a mammogram, if you have dense breasts, it doesn't always show the breast cancer because breast cancer is white and breast tissue is white on a mammogram. So it's like trying to find a snowflake in a snowstorm. It can be really tricky and hard to see. And so mammograms are still important because you can find little tiny specks of calcium, and those can be the very earliest sign of cancer, and you can't see that with any other modality. Mammogram is the only one that will show that. So you should still have a mammogram. And also, sometimes the cancer looks like normal breast tissue. It just happens in an area that wasn't there the year before, and that's the first sign. And so that may not show up on any other modality either. So mammograms are still important even if you have dense breasts. So I just wanted to bust out some common myths and try to maybe talk about them a little bit, because I see this a lot in here in the breast center, people just talking and saying, well, I don't have risk because no one in my family's ever had a breast cancer, so I'm not going to get it, so I really don't need to come every year. I don't need to be as careful. This is not true for multiple reasons, but so genetic cancer is an important thing to pay attention to. If there's a lot of cancer in your family, yes, you should definitely be aware that you might be a carrier of a gene that does express cancer, but only about 5% of breast cancers are related to genetics. So 95% of the time, if you have a cancer, no one in your family will have had it, and it will just be a random mutation. And so it is important to know your family history, but also know that that's not the only thing to pay attention to. A lot of it is environmental, and also time of exposure to hormones. So estrogen and progesterone are the 2 main hormones that women make. Men make it too. And you make the pre-estrogen and you make the pre-progesterone, and those are important hormones because breast cancer can have little receptors or antennas for those, and that's sort of it can feed the cancer, if that makes sense. And so the longer you're exposed to estrogen and progesterone, the higher your chance. I'm getting a 2-minute warning. Another myth is I don't have to start screening until I'm 50 because that's what some organizations say that, and I can also skip a year. That is not true. Between ages 40 and 50, 1 in 6 of those cancers are in that age group. So it's a very important age group, start at 40. So don't pay attention to that. Screening causes exposure to radiation, which is dangerous. This is also not true. It's a very safe, low dose. For example, if you were to fly from New York to California, that amount of radiation is the same amount as a mammogram. So don't fly if you don't want radiation, right? Also, living in Colorado, you get 5 times more radiation than living at sea level, like Oklahoma. So background radiation is about what we call 3 milligrays or 3 millisieverts a year. A mammogram is 0.4 of that. So it's about 2 months of background radiation. So if you're alive for 2 months, you're getting radiation exposure just from the sun, just from being outside, just from your iPhones and whatnot. So it's really a low dose, so that should not deter you. The risks are way low and the benefits are way high of finding breast cancer. Breast pain is a sign of cancer is another myth. Breast cancer does not hurt. Breast pain does not mean that you have cancer. You should pay attention and figure out why you're having the breast pain, but a lot of times it's just hormonal and it's just your body going through changes. And if we had a cure or a cause or a reason or could figure out breast pain, we would like solve a lot of problems because so many women, that's just a bothersome thing. But it's just kind of part of life. You just have to kind of figure out what's causing it, decrease your caffeine intake, decrease your chocolate, decrease your stress level. And then here's another one. A mammogram and having a biopsy can cause the cancer to spread. I've heard people say this. It is so not true. So when you do a biopsy, it's not going to make those cells go everywhere. It's not going to drag them, to other parts of your breast tissue. It's a closed system. The device opens and closes, and it's contained within that little chamber, and we pull it out and we stick it in a jar. So I'm not spreading it. And also when you have a mammogram, we're not spreading anything around. Another one is if you have breast implants, you can't get screened, or that your breast implants may rupture. I'm not going to say it's never happened because I think it might have happened once or twice. I think I've heard one case of it happening if you have saline. But so what we do is we push the implants out of the way and we image the tissue without the implant. And then we image the tissue with the implant with a very light compression. The only downside to having implants is you can't get all of the breast tissue imaged, so the tissue in the back doesn't get imaged very well. So if you have implants, you need to be aware of that and make sure you're doing yourself breast exams and maybe think of a different way of screening like ultrasound or MRI. I don't know how to go back. I accidentally went to the next one. So screening mammograms are important, but they don't always catch all breast cancer, so make sure that you are doing your self-breast exam, your clinical breast exams, you know what to look for. Dimpling of the skin, discharge in the nipple. It's way in the back here. These are just different modalities that I was going to go through, but I don't have time. Oh, shoot. Okay, it's gone. So nipple discharge that's clear or bloody is important to pay attention to. That can be a sign of an early sign of cancer. Skin dimpling, nipple retraction that's new that doesn't come back out. A lump, of course. Pain is not one of them. A lump in your armpit, it's important to feel for that too. Those are kind of some of the common signs. It's okay. I'm out of time. So hopefully I answered the most basic questions, but if you have more, I'm around and I can answer some more questions later.
And while they're pulling up my presentation, I just wanted to give a shout out to this facility. I actually got my mammogram done here and they were amazing. They have warm lube. I also got ultrasound done. And it's the little things. It's the little things that matter, the parking and the lube. And I promise Stephanie's not paying me for this. I literally was so impressed, and they had like the cutest gowns to change into, so it's my favorite place to get a mammogram. So. All right, let's talk about some gut health and GI. So I'm also doing this second year in a row, and I wanted to sneak in some of the most common GI diseases very, very quickly, because I wanted to empower you guys to be able to ask the right questions or know when to seek help or see your gastroenterologist. So just few quick slides on most common diseases before we get to colon cancer screening. So we'll go ahead. All right, so why is GI health important in women, right? This is a no-brainer, but sometimes it's important to kind of realize why women's health matters. Importance of early diagnosis. Early diagnosis means more options for treatment and prevention. And we can really impact our health. Most of the time, we're the nurturers, we're raising families, we're taking care of our husbands, we just forget about our health. So very, very important. Unique risk factors for women. Well, we have different anatomy. We have breasts, we have uterus, we have, all sorts of different, not only anatomical structures, but how they interact with our hormonal regulation. And lastly, connection between GI health and well-being is so, so strong. The brain and gut, it interacts so, so strongly together. And I often tell my patients, we've heard for so many decades that, oh my God, I'm feeling butterflies in my stomach when you get excited. Well, why is that? It's the dumping of neurohormones in your gut. And gut is the epicenter of our immunity as well. So all the reasons why this is very important, to seek regular checkups, pay attention to your gut health. So one of the most common GI diseases is irritable bowel syndrome. Irritable bowel syndrome is very, very different than inflammatory bowel disease, which is Crohn's and ulcerative colitis. Irritable bowel syndrome affects 45 million adults just in USA. So abdominal pain, abdominal bloating, and it is different types. So you can have IBS constipation predominant and IBS diarrhea predominant. And to make things even more interesting, you can have IBS mixed. So if you're having abdominal pain and changes in bowel habits, like persistent diarrhea for more than 3 months, and your bowel habits, after having diarrhea, you're feeling much better, and it's triggered by stress, anxiety, you most likely have IBS. Having said that, if you are having these symptoms abruptly and acutely, of course you gotta see your primary care physician and GI to make sure it's nothing more serious. But irritable bowel syndrome is absolutely manageable. Diagnosis is a diagnosis of exclusion. Okay, so it's based on your presentation, the Rome 4 criteria, like I mentioned, abdominal pain, pain relieved by defecation or associated with defecation. And dietary modifications is a big element in the treatment. So lactose intolerance often is associated with IBS, so a lot of times you can't have dairy, or dairy would be a trigger, and then low FODMAP diet. Okay? And then there are medications out there like Linzess, Trulance, IBS-Rela for IBS-C, rifaximin for IBS-D. So those are kind of the main principles of IBS. Of course, I can talk about each disease for an hour, so these are just quick tips. Celiac disease. A lot of times people think of celiac as it's an allergy to gluten. Well, it's actually an autoimmune process. So what is happening in your body is making antibodies against gliadin, okay, which is a protein, and that's what's causing inflammation of your small bowel villi. So the little finger-like projections that help us absorb all the nutrients, well, they get inflamed and swollen, and they cannot absorb anymore. So a lot of times celiac presentations are anemia, because you're not able to absorb iron, vitamin D deficiency, weight loss. So those are some of the things. And of course, people are feeling pain, bloating, just not feeling good. And it is definitely more prevalent and common. So the diagnostic testing involves blood testing, and EGD with biopsies, duodenal biopsies. So EGD, you're asleep, it takes about 7 to 10 minutes. We take a little camera, we go inside, and we take tissue samples. That's the best test. But there is a very good blood test that tests for anti-TTG antibodies as well. And of course, the treatment is gluten-free diet. So a lot of my patients were like, I take anything gluten and I have severe symptoms. I do have to have a conversation with them in terms of how important it is for you to know you have celiac when you are so symptomatic. Because the treatment is going on gluten-free diet, a strict gluten-free diet. And what I really want you guys to know is if anybody is testing you for celiac, you have to be on a gluten-rich diet. A lot of people are already avoiding gluten and then they're getting tested and they get false negatives because you're already getting treated, okay? So you have to be provoked. You have to, my celiac patients, I literally tell them, eat all the breads and pasta before, okay? So definitely something I want you to advocate for yourself. If you are getting tested for celiac, make sure you do that, okay? GERD, reflux, also known as heartburn, there is, main thing I want you to know about that is if you're having heartburn 3 times a week or more, see your doctor. That's not normal. 3 times or more, or nocturnal symptoms, nighttime symptoms, where you're waking up, regurgitating, having nighttime cough or bitter taste first thing in the morning, that's not normal. We want to make sure your reflux is controlled. And my biggest takeaway here is 6 foods. Avoid the seafoods. Citrus foods, coffee, chocolate, cocktails, cigarette smoking, and curry and spices. So high acid food. I know. If you have bad GERD, that's the quickest ways to get relief. And I know I'm going over time, but I will wrap it up here in a second. Gallbladder disease, right upper quadrant pain is the big one, but gallbladder is the ultimate mimicker. You can have a persistent nausea, you can have bloating, maldigestion that's coming from gallbladder. So gallbladder is truly the great mimicker. If you're having symptoms that don't fit the right upper quadrant, typical pain or nausea, it can be your gallbladder. And the biggest risk factor for gallbladder are female, above 40, 40 or over, and fertile. So after pregnancy, during pregnancy, gallbladder disease, very common. So I'm going to skip the diverticulitis because they're going to kill me, but let's get to colon cancer. Colon cancer is the second leading cause of cancer-related deaths in USA. And some of the celebrities you may know, Chadwick Boseman, Ronald Reagan, Sharon Osbourne, all these, Ruth Bader Ginsburg, all of them had, Audrey Hepburn, all of them had colon cancer. Well, why is it so important? We have 1 in 23 lifetime risk of colorectal cancer in men, 1 in 25 in women. We're finding cancer in younger and younger people. I just scoped a patient, 34-year-old female, who I found colon cancer and her only symptom was bloating. We are seeing this all across, okay? The great news though, is it's preventable, okay? So quickly, cancer usually starts like this. This is a pedunculated polyp. This is what polyp looks like. It is basically an abnormal growth, just like a mole would be on the skin, but inside your colon. And it has the potential to turn into cancer. And what's great is we can prevent it by removing these growths. So what are the tests available? Colonoscopy is the gold standard. We have stool testing, which is the FIT and FOB testing. FOB testing is now very old and have fallen out of favor. FIT testing is DNA-based, so that's like Cologuard that I'm sure you guys have heard about. That's the DNA testing. Flexible sigmoidoscopy, which only goes to the left colon, not the entire colon, and then CT colonography. So this is what a colonoscopy looks like. You come in, You get medication, you're asleep, you don't feel a thing, you don't feel pain. Actually, the procedure itself is quite painless. I take this very sophisticated tool, I go all the way in your colon, and I'm examining for everything. Diverticulosis, neuroendocrine tumors, colon polyps. And it's a one-step test. That's the difference, because in one test, if I see polyps, I can remove them. 90% of the polyps, I can remove them. And if I find cancer, I can biopsy and get the early treatment started. Very, very important. This is the new kid on the block, Guardian Shield blood test. I don't know if you guys have heard about it. It is a good option for people who absolutely don't want to do colonoscopy. So the data is, there was a study of 7,800 patients. It is FDA approved, by the way. 87.5% sensitive for stage 1, 2, 3 colorectal cancer. The biggest takeaway I want you to know about this, it's a good test if somebody in your family absolutely refuses to get colonoscopy, but it's quite weak in detecting advanced polyps. So the polyps, when they are in the stage of going from benign to cancer, they have advanced features. That's when we want to remove them. So it doesn't do that good of a job with that. So it's probably the biggest con. 45 is the age to get screened. 45 is the new sexy 50. And this is what you can do for your colon health, to prevent colon cancer. Limit alcohol and red meat. I know, first I take away your chocolate, now I'm taking away your red meat, I get it. Get screened. Plenty of fruits and vegetables, 150 minutes of physical activity per week, and no smoking. Okay, I'm gonna skip this. Yeah, so thank you so much. Thank you.
I'm Julie Wiley. I'm an OBGYN here in Oklahoma City. I'm talking about cervical cancer screening. And I think most of us are obviously familiar with pap smears. Have hopefully all had our pap smears. And I think a lot of times my mission as a gynecologist who are seeing women for wellness exams is to make sure they're getting to the dermatologist and to their mammograms and to their colonoscopies. But pap smear is still super important. And there's a lot of confusion sometimes, I think, about what a pap smear is, even though we all get them. Coming to see me for an annual exam or well-woman exam is not the same as just a pap smear. Same with a pelvic exam. A pap smear is just a small part of the pelvic exam. And that's where we're collecting cells from the cervix and we're sending it off to look for abnormal cells. Those abnormal cells over time can progress to a cervical cancer. So while HPV causes abnormal cells in cervical cancer, the pap smear itself is not a general STD screen. That's a different part of the pelvic exam. Pap smears, they're quick, they should be quick, and they can be life-saving, super, super important. I think a lot of us grew up scared of pap smears and there's a lot of fear around them, and hopefully, my goal is to make sure that they're not scary. So when do we start? This is kind of the mind-blowing part, I think, to a lot of people, maybe of the generation here, but I think a lot of us grew up in a time where pap smears were started as soon as you started having sex, as soon as you were a teenager, 15, 16, 18, but really 21 is kind of a hard rule outside of a few very small exceptions. Regardless of sexual activity, pap smears start at 21. Now I see lots of younger girls for things like contraception, abnormal periods, things, STD screening, but pap smears 21. And then from the age of 21 to 29, they're every 3 years with reflex HPV testing, meaning if the pap smear is abnormal, then we'll test for HPV. But then starting at 30, they're every 5 years with HPV testing automatically. At the age of 65, or if you've had a hysterectomy and you don't have a cervix any longer, it's important to know if your hysterectomy included removal of the cervix or not. If you've never had any abnormals or recent history of abnormals, history of severe, then you can stop screening pap smears. Doesn't mean you have to or get to come stop coming to see me. But the pap smear part of the pelvic exam, we don't need any longer. So abnormal pap smears, almost all the time caused by HPV, human papillomavirus. Over 90% of cervical cancers are caused by HPV. There are many strains of HPV. Some of those cause plantar's warts, warts in general, genital warts, but there are specific ones that cause cervical cancer. And then within that, there are some subsets of strains that cause high-risk cervical cancer. So where does the HPV vaccine come into this? Protects against those most dangerous strains of HPV. Does a very good job at this. We know that since the HPV vaccine has been around, that our globally cervical cancer rates have declined dramatically. So it's best to start that series before somebody is sexually active. So 9 to 12 is ideal, can be up to 26 in that initial, but there's new data, new recommendations over the last 5 years that we can give that now through the age of 45. So all of us that grew up when the HPV vaccine was not available, now we can go get that. So it's a cancer-preventing vaccine, which I think is so unique to the HPV vaccine. It's one of the only vaccines that we have that prevents cancer. So it's not just an STD shot. It does not give young people permission to have sex. That's not what it's about. It's about preventing cancer. And I have, just like Dr. Singhal was talking about young individuals, I have lots of patients who have passed because of not getting pap smears, not getting, I have a patient who's raising her young grandson because his mom passed away. Like, it's just, the prevention part is so key here, and getting pap smears, preventing with the HPV vaccine. It's one of the safest vaccines that we have. There's so much misinformation and fear around the HPV vaccine. Of all the vaccines we have, it is the most studied, it is the safest. People ask me all the time, well, would you get it for your daughter? 1,000%, already done, would do it in a heartbeat. But it's not just for teens. Like I said, we can, the HPV vaccine is approved up to 45 years old, so that would be people who maybe have multiple partners, new partners, those who were not vaccinated as a teen. Again, 90% of cervical cancers are caused by the HPV vaccine, but also throat, anal, penile cancers. So back to pap smears, why they're important. Feel fine, why do I need to get a pap smear? Cervical cancer, until it's very, very progressed, has no symptoms. So things that somebody might notice is abnormal bleeding, bleeding with intercourse, problems with urination or bowel movements, and those things are a problem because the cancer has already progressed, it's already spread to nearby tissues, and so dysplasia, cervical dysplasia, which is the precursor to cancer, and early cervical cancer really has no symptoms at all. So it's important for us to catch those things, and that's the intention of a pap smear, so that we can catch those changes really early before they ever progress. And I tell patients all the time that as long as we're staying on top of our pap smears, and even if they are abnormal and we're staying on top of the management of them, it really should never ever progress. So some common myths that we have in relation to cervical cancer, and so I've had the HPV vaccine, I don't need to get pap smears, I'm protected. That's not true. The most recent HPV vaccine is a 9-valent vaccine, meaning that it covers 9 strains of HPV, but that's not all of them. So it's still very, very important to get pap smears. I've only had one partner, so there's no way that I could get HPV. Really, the only person that you can know for sure about right is yourself, so you don't know how many partners your partner's had. And so, they're just still really important. And well-woman exams in general, even if it's not cervical cancer, there's lots of other things we're looking for, vaginal cancers, different things like that that we're looking for besides just the cervical cells. Pap smears are painful. This is a little bit of a soapbox of mine. I think a lot of people do have fear and worries about getting a pap smear, and really they should not be painful. They may be a little uncomfortable, could feel like some pressure, but if they're painful, we need to stop and reevaluate and do something different. So, speak up if you're having a lot of pain, like, let's do something different. So cervical cancer, easier to prevent than treat. And then just like for all of us here, make the appointments because we're all worth it. Prevention is key, screening is key. That's all I got.
So my portion of this is actually quite short. I kind of tail end on what Dr. Wiley tells you about because I am a general surgeon that does a lot of anal, perianal, and pelvic health. So that means I take care of a lot of anal lesions. So the newest thing that is being studied and we're trying to prevent is anal cancer. And we know that nearly 100% of anal cancers are caused by HPV, the virus that is that you can vaccinate against with the Gardasil vaccination. So what is interesting about this area is it's what's called a transition zone. So it's a very important part of our body that changes from the skin cells to kind of a moist mucosal lining. It is impacted by our hormone status. It is impacted by viral illnesses. And the same things that can change our cervical tissue can change our anal tissue. So we're right at the beginning of this, starting to screen for abnormalities in the anal tissue in hopes of trying to prevent progression to anal cancer. What we think this will likely look like is an anal pap smear. Right now, I am doing this on high-risk patients, most of which are immunocompromised and already have a proven history of HPV. Insurance is covering it so far, but we haven't made it available as a screening. So I just wanted to talk about that and make sure that everyone knows to pay attention not only to their vagina, but also their anus. It's also very, very important. And something to just cover over everything that we talked about. All of our screening is looking at tissue that started out as normal. Our normal skin, our normal breast tissue, our normal cervical tissue, our normal anal tissue. And something happened to the proofreading mechanism. And as that tissue made copies and copies and copies, it becomes more abnormal and eventually becomes a skin cancer. And because of that, most of these we can prevent and stop. We have an abnormal finding on skin, we can take it off and hopefully get it taken care of with minimal intervention. Have an abnormal finding on mammogram. If we stay consistent, we catch it more quickly. Have an abnormal finding on colonoscopy, a polyp. It's that first spell check problem. We snip it off and stop the process. We prevent the colon cancer. Cervical dysplasia, we do a colposcopy, treat it, and actually prevent the progression of cervical cancer. Anal cancer, I'm hoping to be one of those trailblazers and be right at the front, that when we start finding these abnormal tissue cells, I'll have more options. Right now I have a couple treatment options in clinic, but nothing that's great and proven yet. All right.
I think she's the only one who finished on time.
Good job, Dr. Enix, good job. So I really appreciate all of you guys and the importance of screening. And so we're going to do a couple of things real quick. We can do 5 questions. So if 5 different people want to ask any one of our experts a question, and then we'll take a quick break and start over again. So questions?
There are giveaways.
There are giveaways. There are giveaways.
I have one on the anal care, since it's new to me. So when you talk about prevention, what kind of care do we do for our anus on a daily basis?
So, what's really important, and I have a presentation towards the end, it's GI regularity and minimizing trauma to the area. Okay, perfect. So GI regularity, minimizing trauma to the area. So unfortunately, Dr. Singhal didn't get to talk about her fiber slides and her probiotic slides because our presentations dovetail nicely together. So soft, easy to pass bowel movements. I hate toilet paper. I wish everyone would transition to a bidet, but it's not as accepted here, so at least wet wipes with witch hazel in them, minimal time on the toilet. And then of course, if we have a history of cervical dysplasia, and especially in the setting of any sort of history of anoreceptor intercourse, then we want to be sure and not avoid our bottoms. If there's something new or different, a lump Could be a hemorrhoid, could be a skin tag, could be something else. And just don't ignore it. There are people out there that help take care of you.
And this is Jessica.
I'm her daughter, and I do have it today. And I have one too as her friend. It's just how it's all worked out. It's a Christmas present.
We follow what we preach, clearly. Jessica loves to talk about this, and I do too, but squatty potty as well. So a stool that raises our legs to open up our angle so we're not straining. That kind of goes hand in hand with hemorrhoids and anal care. And she's going to talk. I know she has a whole session.
Okay, next question. Okay.
Since the advent of HPV vaccine, is there any studies that say cervical cancer is reduced by so-and-so?
Very much, very much. I don't know that I can quote you the exact number, but it is drastically decreased worldwide since we've had the HPV vaccine has come on the market.
Another question.
I have a question about the slide, role of probiotics, when to take it, how long, and which one?
Yes, the big one. So the big difference real quick, probiotics and prebiotics, okay? Probiotics are live bacteria in our gut, and they are the ones that keep our gut healthy, maintain the equilibrium. Prebiotics are just plant kind of fibers, molecules that probiotics feed on. So that's why the prebiotics, when you take, that are foods that are rich with prebiotics, you get a lot more probiotics. So when to take probiotics? Well, I tell everybody to take them every day in your diet to keep good gut health. But when it comes to diseases like irritable bowel syndrome and having symptoms, there are actually society guidelines that talk about there's no real evidence that they help relieve the symptoms. So there's a fine balance in giving into consumerism where everything is, this is so great for your gut, this is for healthy gut. If you pull up my slide on cold. I wanted to give you examples, and I would encourage you.
Sorry. Cold's going to take care of it.
Yeah. So probiotics food are like the kombucha. Anything pickled is great probiotic. Kefir, very good probiotic. That has the most live number of strains. So instead of spending $30 to $50 on probiotics, incorporating those natural foods are huge. And then there is,
Kimchi one?
Kimchi one, yes, kimchi is definitely one. So there is, and then I wanted to also give you there, prebiotics, thank you. So yogurt, kefir, kimchi, fermented vegetables like pickled, anything pickled, miso soup, great probiotic foods. And prebiotics, asparagus, leeks, onion, garlic, bananas, legumes, seeds. So again, what I was getting at to answer your probiotic question, 2 slides down, is now the standard of eating is Mediterranean diet. And if you really follow Mediterranean diet, you'll have good probiotics in your gut, okay? So,
Since the gut and brain are so interrelated, is
yes.
anything else to do, like meditation?
100%. Meditation, brain, so the neurotransmitters affecting the gut, anything we can do to help with the stress, anxiety, especially the world we live in right now, anything, we get 20,000 alerts a day, anything to calm our mental nerves and improve our mental health. So meditation, yoga, anything that brings you joy. I always tell people, do 5 to 10 minutes of anything that brings you happiness, yoga, gardening, whatever, mahjong. So anything.
Okay, and I just wanted to add on, probiotics and like GI health things are a huge craze right now. So just be sure and check the labels. Clear labels, nothing that has a proprietary blend in it. That means that there's some sort of mixture that they're not divulging to you. And then also watch out for sugar. Kombucha is great, yogurt is great. Most people only like it when it has so much sugar it's practically a donut. And we don't want that because it leads to bloating. And I think that was about it.
I'm going to do one more question and then we'll regroup.
Oh, I don't need that microphone. I was just curious for how accurate is your blood test for celiac? Like, at what point do you need to progress on to the next stage?
Yeah, that's a great question. So the blood test, it depends. There are three, so I would encourage to ask for celiac panel. Okay, it's a complicated answer, and I'm sorry because celiac is very complex. First of all, the antibody assay is IgA based, which is immunoglobulin A, and IgA deficiency is very common. So when you get the panel, we're always testing for the IgA levels, because if you're deficient, it's not a big deal, but that panel is going to be false negative. But if IgA is normal and the TTG is positive, it's about 97%. Yeah.
All right, I'm excited to talk about this because I feel like we all are inundated with social media discussions about hormones, hormone replacement therapy, menopause, perimenopause, all the things. So I'm excited to talk about this, and I would say it's become one of the most common requests that I get from patients is, I want to get my hormones checked. Everything that's wrong is related to hormones, right? Or so we all think, but Dr. Wiley again. So what is menopause exactly? How long does it last? When does it end? So menopause technically, by definition, is 12 months, 1 year without a period. Average age is 50 to 51, but just like any average, right, some women are going to be before that, some are going to be after that, but it's officially postmenopausal after 12 months of no bleeding. So perimenopause and menopause, really the symptoms of those are the same, very similar. Perimenopause, you're still having periods though. They may or may not be regular. Menopause, we're done bleeding. And postmenopause just means that you've kind of passed that 12 months. So what exactly is perimenopause then? So perimenopause is this kind of pre-game, this like lead up to menopause. And that can look so different for everybody. Not two women experience perimenopause and menopause the same. So some women will just kind of track along regular monthly period and they just stop. Maybe they have no symptoms at all. Some women have this terrible irregularity with their periods. Maybe they're heavy, maybe they're painful. Maybe they have a few symptoms, maybe they are miserable with symptoms. But it truly is different for everybody. It can start in your late 30s or 40s, and just like that it's different for everybody, the duration can be different. So, you know, for some women it may be a few months of symptoms. For some women it may be years or a decade. So the reason for this is estrogen and progesterone are kind of declining through those perimenopausal years, or they're not cycling typically or normally. So how do you know when you're fully there? Again, it's the 12 months, and then here is the symptoms of perimenopause or menopause. It could be irregular periods, abnormal periods, hot flashes, night sweats, mood changes, weight gain, fatigue, joint pain, libido issues, vaginal dryness, painful sex, kind of this brain fog, forgetfulness, any or all of the above. So kind of what's happening here. So menopause is where your ovaries are just done. They're not functioning anymore. We all have female hormones that are made in our brain that talk to our ovaries, and our ovaries make hormones that then tell our uterus what to do every month if we don't get pregnant, right? So what's happening is your ovaries are not they're not producing healthy eggs anymore, you're not ovulating, and so then they're also not making estrogen and progesterone. And so this kind of goes hand in hand with ovulation. As those estrogen levels start declining, that's when we start getting perimenopausal symptoms. This includes surgical menopause. So this is, you've had your ovaries removed for whatever reason. Maybe you had cysts, maybe you had a hysterectomy, but your ovaries have been removed, and that can cause kind of sudden, even sometimes some more severe symptoms of menopause. I think what's important on this slide is that lab values, contrary to what we all hear often, lab values are not the end-all be-all for perimenopausal diagnosis, menopausal diagnosis, and even treatment. So this is kind of a broad look at 6 months of what our cycles do normally before menopause. We're ovulating, we're cycling, we're having periods, and it's this constant cyclic thing with our each of those female hormones. In perimenopause, though, things are not talking together normally, and so things are kind of all over the place. All of those hormones are kind of sporadic. It changes day to day, and so it changes. Once we hit menopause, those levels are pretty static. And so I think this is important because sometimes I'll have somebody who's been in menopause for 5 years, and they say, I need to get my hormones checked. Well, it's not really necessary because your hormone levels, they are what they are. You know, we're really here to treat symptoms at that point, not a lab value. So again, here, like I could check it on a Tuesday and then maybe 2 weeks later check it, it's gonna give me a different value. And so really the key here is that, you know, we're not aiming to check hormone levels, replace estrogen to a certain level, replace progesterone to a certain level. It's really about symptoms. Now, we do check lab values sometimes because often we're either ruling out thyroid disorder, maybe vitamin deficiencies, anemia, some things that can cause, other things that can cause menopausal and perimenopausal symptoms, or to just kind of say like, oh, yep, you are menopausal. But, you know, it's not the end all be all. Estrogen does a whole lot more for us than just make us have a period every month and ovulate. So it's good for our bones, right? So that's why we have increased risk of osteoporosis, osteopenia as we get into our menopausal years. It's good for our heart, good for our brain, supports vaginal and urinary health. It affects our mood, our skin. So this is where we start seeing most of our, you know, kind of facial skin signs of aging as our estrogen levels start to decrease in perimenopause. So what is the answer? So hormone replacement therapy is really, it should be personalized, it should be evidence-based. So there are many, many options for estrogen and progesterone hormone replacement therapy. Both of those, this is important, are very necessary if you have a uterus. If you have a uterus and you haven't had a hysterectomy, you have to have progesterone with the estrogen. Estrogen alone can increase your risk of endometrial cancer. So the progesterone is there to protect your uterus. Comes in lots of different formulations, so transdermal, oral, topical, vaginal formulations. One is not better than the other. I a lot of times have patients who will say, okay, what's the best HRT? Like, I want the best one. And there's not a best one. It's what you feel best on, what you tolerate. You know, I've seen patients who are like, I don't want to take a pill every day, and so maybe a patch is better. Or I have patients who maybe a patch doesn't stick to their skin and they would rather do an oral medication because they take other oral medications every day anyways. So it really is personalized, individual. It's what makes you feel the best. Sometimes we don't get it right the first time because what works for you may not work for you and vice versa. And so it's not one size fits all. Sometimes there's some trial and error because we may try something initially that maybe that's what we think is going to be best for you. Maybe that's not the answer and we need to go a different route. So there is some trial and error. There's not a perfect one for everybody. There are lots of safe and effective options, especially when we start them at least within 5 to 10 years of the onset of menopause. So the key to this, again, when we kind of think back to the graph, we're not treating lab values, we're treating symptoms. So I kind of think about it like if you're diabetic and your blood sugars are running here, we need to give you this much insulin to get your blood sugars down. Hormones do not work like that, and this is why lab values are, again, not the end-all be-all, because it's not that if your estrogen level's here, we need to give you this much estrogen to get it to this level. It's really not about that. The lab values aren't important. There's also no role for repeating hormone values every 3 months, every 6 months. You know, it's really about managing your symptoms. So there are some other non-hormonal options to treat perimenopausal symptoms. Veoza is a newer one that is specifically a non-hormonal option for hot flashes. We know that SSRIs and SNRIs, which are antidepressants, work really well for hot flashes. So sometimes I have patients that maybe their only symptom is hot flashes and mood changes, and sometimes they'll opt for this because it does a really good job for those two things. Gabapentin can be really good for that as well. Sometimes I have patients that their only symptom is vaginal dryness, and so a vaginal estrogen cream or suppository can be really great for that. There's a lot of lifestyle modifications, which we'll talk about that a bit more. Supplements carefully, so vitamin D, calcium is good for our bones, right? Magnesium can help with some of the brain fog, sleeping, and then omega-3 fatty acids are always good. There's a lot of non-evidence-based things that are available that I think are commercially pushed. So DIM, DHEA, we talked about the proprietary blends, hormone balancing, that's not a thing. Natural does not always mean safe, and I think we are, again, inundated from social media about take this, or, you know, if your doctor's not listening to you, you should take this, you know, to make you feel better, and it's really about this, not about your health. So some lifestyle things that can be helpful. You know, if you're having a lot of issues with hot flashes, dress in layers because those hot flashes come and go. Avoid alcohol and caffeine, hot beverages, regular exercise. We know those things can help with menopausal symptoms. Sleep issues, good sleep hygiene, limiting alcohol, cut caffeine. And later in the day, we know that cognitive behavior therapy can help with insomnia. Also, sleep apnea. You know, do you need to get checked for sleep apnea? Mood changes, anxiety, irritability are really common in menopause and perimenopause, and so physical activity, proper nutrition, therapy, counseling. As far as the brain fog, again, sleep is so important. Exercise, mental stimulation, so like puzzles, mind games, limiting multitasking so that we can kind of help narrow our focus a bit. Weight gain's a hard one. We know that weight gain in menopause is a result of our decreasing estrogen levels. I could, though, give you all the estrogen in the world, and it's not going to just make our weight gain from perimenopause fall off. So that's a tough one. We know that it's associated with menopause. We don't have a perfect solution for that, but Dr. Singhal will talk to us about it a little bit. But we know strength training is good. Again, that's good for our bones. Protein intake, fiber-rich foods. What is not the answer? This is where I'll get on a soapbox a bit. So tons of marketing and push for pellets. They sound great. The marketing makes them sound like a perfect solution. They are not. They are not FDA approved for menopause. They've been around a while, and you know, my thought is that there's a lot of money in it, and if they were safe, they would be approved at this point, and they're just not. There is not any large independent randomized controlled studies, which is the gold standard, right, for medical treatment that support the use of pellets. In fact, the two main kind of governing bodies in OBGYN, the Menopause Society and American College of OBGYNs, both have statements against pellets. They often have too much testosterone, too much estrogen, not enough progesterone. They have really inconsistent dosing, so a lot of times what patients will report is that they feel really great at first with their pellets, and then you know, the levels decline, and then they don't feel good. And then they get them again, and then they feel good, and then it goes down. Lots of side effects that are undesirable, hair growth, acne. So I have women who are 55, and they're getting pellets, and you know, then they're like, why do I have all this facial hair? Why do I have acne like when I was a teenager? Mood swings, as you can expect with testosterone. I've even had patients that have enlarged clitorises that they're like, what is happening? And then it can be hard to reverse. Once it's in, you just got to ride it out. We have, again, better, safer, FDA-approved, evidence-based options for hormone replacement therapy. This is, I really like this physician. She, if you're looking for somebody on social media that gives accurate, evidence-based information in regards to menopause and hormone replacement therapy, Heather Hirsch is a great one. I put her Instagram there. But she just recently posted, and I thought it was just kind of hit home. Pellets are unregulated medications. They're not FDA approved. They have never been well studied in long-term studies, and we do not know their long-term safety. And we also don't know their short-term safety either. You should be appropriately counseled on FDA approved hormone therapy. Okay, so here's some myths. You know, again, social media, hormones everywhere. I do think it's always a little bit ironic that, you know, social media has made lots of really young women terrified of hormones, terrified of birth control. It's bad. People are selling hormone cleanses. And then we've got middle-aged women who are hungry for hormones because social media tells us it's going to fix everything in our life. But here's some kind of main points that I think social media causes a lot of confusion about. Bioidentical hormones are safer because they're natural. Bioidentical is a false term. So bioidentical just means that it's chemically similar to hormones made in our body, or a substance made in our body, right? Any FDA-approved hormone is going to be bioidentical as well. If it wasn't, it wouldn't work. And so that really is just a marketing term. I kind of equate it to somebody trying to sell you organic sugar cane crystals. Well, it's just sugar, right? It's not fancy. It just has a fancy name to make you buy it and spend more money. So another thing that I hear a lot, pellets are the best because they're long-lasting. So are side effects. They're also very expensive because they're not FDA approved. You're paying cash for them. So I have women who are paying thousands of dollars a year for pellets because insurance doesn't cover them because they're not FDA approved. And then this has come up for me a lot. I've had patients that come like, well, I've seen this hormone expert and, you know, blah, blah, blah. Just be very leery of people who call themselves hormone experts. If they're not an OBGYN or an endocrinologist, they're probably not a hormone expert. I mean, we went to 4 years of training to be a hormone expert. Not a weekend course. We're not there to give you a sales pitch because we went to a weekend course from a drug, a compounded hormone that they're trying to push, right? So I would be very leery of anybody that calls themselves a hormone expert or a hormone clinic or a wellness clinic that's pushing hormones. So, red flags, if you're paying cash for your labs and you're paying cash repeatedly for labs, you're buying supplements. If the person that's trying to prescribe you hormones is selling you supplements, they're selling you hormones that are outside of what your insurance covers, chances are you're funding their business model and not your health. So I think that's a huge, huge thing. You can read it again because I think it's important. So some key takeaways. So menopause, perimenopausal symptoms, you're not imagining it. They are real. They affect many parts of our bodies and our moods. You do not have to suffer. We have lots of safe, evidence-based, FDA-approved options and lifestyle support options. Be picky about your sources. Your hormones are not a trend, even though, you know, social media has made them that. Trust trained professionals and not influencers or hormone clinics trying to sell you a magic solution. I think that's it. Okay.
A big shout out to Dr. Wiley, who also delivered my baby. I'm so proud of her. She has her independently owned practice in Bloom. So a big shout out to Dr. Wiley for being here and all our speakers who are volunteering their time out of their own goodwill to promote good education. So thank you. All right, so my topic, which I'm pretty sure I'm not going to stay on time, but I'll try my best, GLP-1 medications, okay? So the Ozempic phenomenon. How does a gastroenterologist get into this space? I'm a board-certified obesity medicine specialist. I got into this space because of you guys. I'm also a hepatologist. I was seeing a lot of fatty liver disease in Oklahoma, and my female patients were like, I'm tired of hearing diet and exercise and literally like help. And I found myself to be undereducated. This was not a thing when I was training in medical school, so I had to go get more trained, and that's how I went and got certification, and now I'm in this space. So why is this important? Obesity epidemic. The orange and red are bad. Okay, those are the states where there's greater than 35% obesity. You see the trend from 2011 to 2018. Oklahoma is definitely there. It's projected, why is this an epidemic? It's projected that our prevalence is going to be 50% of United States is going to be obese by 2030. That's less than 5 years away. This is a huge crisis. So what do we do? And you guys all know the pillars of weight loss is really, they are the fundamental pillars. You can't escape the diet and nutrition. You cannot escape good exercise, building lean muscle for good metabolism. But most recently, we do have some great medications that work if taken appropriately. And GLP-1s are those drugs. So let's talk about it. What is GLP-1? Well, it's a hormone. And this hormone, it mimics, it helps stimulate insulin secretion. So GLP-1 affects all these organs in a good way to achieve weight loss. And how does it do it? It increases insulin sensitivity. It decreases glucagon. So our fat stores, glucagon is responsible for that. So by decreasing that hormone and increasing insulin, it really, really helps with a lot of cardioprotection, a lot of liver protection from deposition of fatty cells. It slows down gastric emptying and delays that emptying so you feel satiated. It also works on a hormone called ghrelin that it gives us a trigger in our brain to feel that we are not hungry. So it really curbs our carbohydrate cravings, okay? So again, increased insulin secretion, decreased glucagon, it delays gastric emptying, and that leads to a lot of GI side effects, nausea, vomiting that I'm going to talk about. So what are the medications, GLP-1, out there? So GLP-1 has been around for 20, 30 years for a treatment cornerstone in diabetic world, okay, because of the insulin. But what we have actually approved, FDA approved for weight loss, are these three medications. Semaglutide, known as Wegovy, actually not Ozempic. Even though it's an Ozempic phenomenon, Ozempic itself, packaged and branded, is not FDA approved for weight loss, and that's why you cannot get access, the correct access to it. Wegovy, however, is, which has the same compound, semaglutide. Liraglutide, which is also known as Saxenda, and tirzepatide, which is a dual hormone agonist, which is known as Zepbound. A lot of you guys may know this as Mounjaro. That is actually not FDA approved for weight loss, and that's why you can't get it. Insurance companies won't cover it. So some key things to keep in mind with GLP-1, they are often prescribed in higher doses than diabetes treatment, okay, for weight loss. Most of them are injections, sub-Q pens, that you do weekly, except for Ribelsus, which is an oral medication. Some of them are approved for kids and adults, so it's not limited to just adults. So you see here, Wegovy is approved for kids and adults, liraglutide, even Saxenda. Oh no, it didn't show up, but this was the slide about the evidence. The three medications, do they actually work? What is the evidence? So they actually really do work. Liraglutide has been proven in large studies to have 5% of total body weight loss. Semaglutide has had up to 12% of total body weight loss. And tirzepatide, which is the new kid on the block, why everybody went from Ozempic to this Mounjaro phenomenon or tirzepatide, it has up to 20% total body weight loss, okay? Sorry that these did not project well, I'm not sure. What is tirzepatide? It's a dual mechanism. So it works on GLP-1 and it works on GIP. And that's why the additional benefit. So let's talk about, whenever we're talking about this, right? We all know it works. What are the contraindications? What do I want you to know about these medications? Anybody who has history of medullary thyroid carcinoma, it's a contraindication. Do not take these medications. Multiple endocrine neoplasia syndrome, that's a contraindication. So, you know, do not order these medications off of website in Canada because there are actual contraindications, and it should only be taken after a detailed history, a detailed family history, because these contraindications are real. Warnings, there is risk of thyroid tumors. There's also a risk of actually pancreatitis, which is pancreatic inflammation. The risk is low, but it has to be monitored and make sure that you don't have a complex pancreatic disease history to put yourself at increased risk. Hypoglycemia and kidney problems due to dehydration. A lot of people, when they start on these medications, are not able to tolerate PO intake and they get dehydrated, hurting their kidneys. Hypoglycemia, decrease in blood glucose because of the increase in insulin. And definitely do not share Ozempic pens. Risk of infection. It really should be disposed of after one use. And very, very important to inform whoever is prescribing you, hopefully a physician or a nurse practitioner, that all the other medications, including the other over-the-counter medications you may be taking, like aspirin, okay? Because that's a blood thinner, you can have bruise. It's very, very important. Discuss pregnancy and breastfeeding plans. This is not approved for pregnancy, okay? It's category, all of them are category C and D, which means that it has been demonstrated that there is animal and human fetus harm with these medications. So very important. You see why it's really, really important to do this under a care of a board-certified physician. So what are the side effects? The most common side effects are GI side effects. Nausea, vomiting. So when you delay your gastric emptying, the standard time when this food is sitting in the stomach is about 60 minutes. Your stomach, the whole purpose is it squeezes, moves food along. This medication, instead of squeezing, we're doing this. So food is sitting. It's sitting, occupying surface area in the stomach. You don't feel hungry. You're feeling nauseated. Because if you are, all of us, when we're trying to lose weight, we are clearly eating more portion sizes than we should. So that initial weeks are hard because you keep wanting to eat and there's just no space. It's not emptying properly. Abdominal pain or bloating, intestinal blockage can happen. It can definitely lead to constipation or diarrhea. Some of the serious side effects, which are less common but very important to know, thyroid tumors that I mentioned, pancreatitis, change in vision, especially if you're feeling dehydrated, or you have hypoglycemia, which means low blood glucose, which could be quite scary. Kidney problems, gallbladder problems. So a lot of people will start losing weight very drastically, causing gallbladder to get inflamed or develop stones. Very, very important to know that. And of course, with any medication, serious allergic reactions. So what can we do to avoid these side effects? Well, there are some key things. Taking some crackers, mint, ginger-based food after doing the shot, 20 to 30 minutes after actually can really help with mitigating the side effects. Vomiting, of course, and diarrhea, staying well hydrated. So cold liquids with a straw, sip, are very, very helpful in keeping hydrated. Same thing with diarrhea. Also contacting your physician and talking to them about these side effects so they know how to microdose and adjust the medication is very important. Constipation, enough fiber. Cannot stress that enough, okay? So plenty of water. 92 ounces of water every day is the recommendation, and 25 grams of fiber every day is the standard recommendation for us to keep good health care. So eat slowly, stop when full, have smaller portions, and avoid being too active right after the shots. Ozempic face, and I'm sure Dr. Bajaj may cover this, but this is also a big side effect of being on Ozempic or GLP-1. You start having drastic weight loss and you have a hollowed out face. You can have kind of sagging skin and hollowed cheekbones, sunken eyes. This is probably the sign that you're going too fast on your weight loss journey, okay? And so when to see a doctor about GLP-1 use? The answer is all the time. This slide talks about when to see a doctor for the side effects. Most side effects, like I mentioned, are not that serious. But if you're having persistent severe vomiting, diarrhea, pain that's not going away, constipation, inability to pass gas, that's a sign of intestinal blockage. Jaundice, yellow skin or eyes, that's early signs of pancreatitis or liver enzymes, liver injury. So very, very important. And also for our anesthesia colleagues, if you're about to get a surgery, very important to tell them that you're on a GLP-1, Ozempic, Mounjaro, Wegovy, because the food stays longer and you have a higher risk of aspiration. It could be a minor procedure, but if you're getting anesthesia, please, please tell your surgeon or the proceduralist that you are on these medications. So what are the barriers? Well, the price, the cost. If it works so well, most people can tolerate it, what is the problem? The cost. So just a couple of slides, I'm almost done. Compounded medications, right? Because we can't afford it, now we have so many compounding pharmacies. So why do we all hate, as physicians, compounding pharmacies? Well, because we are evidence-based people. We are scientists, right? So we don't like anything that is not regulated. Compounding pharmacies, they're custom-made medications made by pharmacies. They are not FDA regulated, but they have the same FDA-approved component in them. And just like Dr. Wiley was talking about the pellets and everything, we just don't have that good of a regulation. And that's why it makes us nervous. So lack of FDA approval, variable quality and purity, potential contamination risks, inconsistent dosing, and dosing errors. Having said that, in the era when we know a medication works, and we have shortages, and you may have somebody struggling with polycystic ovarian syndrome, fatty liver disease, obesity, how do we access these medications? The answer is go to a trusted physician who has done their research on compounding pharmacy. There is a role for it, but you have to evaluate risk versus benefit. If somebody is just overweight and wanting to lose 15, 20 pounds, is it worth to go to a compounding pharmacy? Probably not. But if this is going to prevent your diabetes, you're just on that threshold, there may be a role, to go and get this from a compounding pharmacy, a trusted compounding pharmacy. And lastly, what are my takeaways? Obesity is very, very real. Early intervention is the key, and we all have to work together to recognize that this is not, we look what we eat, what the big stigma was with obesity. This is a very complex disease. Okay? And GLP-1 medications are medications with FDA indications, contraindications, and serious side effects. So please, please have a supervised program because that's the only thing that's going to lead to sustainable weight loss. Because the moment you get off of these, you're going to get the weight back. Okay? All right. Thank you, guys.
Dr. Bajaj is a plastic surgeon here in Oklahoma City. She's a board-certified plastic surgeon. She grew up here. She graduated from Cassidy. She went to Rice. She went to Loma Linda, or Pittsburgh first, right? And then Loma Linda, and eventually landed back in Oklahoma City. Her dad was a plastic surgeon here in town as well, and helped with breast cancer reconstruction for years, and now has a thriving aesthetic practice, and so she's going to do some skincare and aging gracefully talks for us. And the battery was dying on the computer, and so you're going to come from this side.
I'm going to go over there?
Yeah.
Okay, cool. So I get to talk about the fun stuff and not the cancer stuff, so that's always different. And thank you, Stephanie. So I wanted to talk more, not necessarily about aging gracefully, but aging with intention. So when we talk a lot about aging gracefully, in the media it can mean anything. It can actually mean no plastic surgery because, we're aging gracefully the way we're supposed to. But I want to focus more on aging with intention and how we really want to age. It's more about an attitude and how we approach life. Because aging is inevitable, and there are different things we can do to slow the process and also age in a way that makes us comfortable in our own skin. And so those fundamental things that will help us are things you've already heard about. Sleep, exercise, sunscreen, good nutrition, and a judicious use of aesthetic treatments is what I'll say. And it boils down to daily maintenance. If we only saw the dentist every 6 months and did nothing to our teeth, no flossing, no brushing, and saw him or her once every 6 months, it would be a disaster. And unfortunately, in my world, that's what I see a lot of from a facial standpoint. Said another way, Fritz Barton is a well-known plastic surgeon in Dallas, and he primarily focused on facelifts. And what he said, no matter how fine the tailoring, you still have to deal with the fabric. And with saying that, he's referring to the skin and the things that we refer to as daily maintenance. And what I kind of joke about in my office is there's no surgery I can do that's going to reverse 50, 60, 70 years of abuse, whether it is related to sun damage or smoking or a lot of the other things that we do because we like it, that's not good for us. So that goes down to what I talk about, the 80-20 rule, which is the maintenance component. 80% of aging and what we can do to age with intention comes from us. And as a plastic surgeon, I can only provide the other 20%, whether it's in terms of surgery or any type of aesthetic treatment. And so the fundamental pyramid is what we've already discussed: nutrition, skincare, sunscreen, and exercise. And that should be your underlying foundation. And everything else comes at the end. In fact, surgery is at the top of the pyramid. It shouldn't be your first line answer. And we talked a little bit about menopause. And as women, I think menopause and perimenopause is really when we start to notice the signs of aging. And primarily that's because we start to see the decreased collagen production with a decreased quality of our skin. And that actually begins in our 30s, not in our 40s and 50s when we're perimenopausal. It started earlier than that. We also have a loss of protection against free radicals from our lack of estrogen, and our oil glands in our skin are also less productive. So during menopause, you'll notice that your skin is drier and more sensitive. You'll also have decreased melanin production and slowed wound healing. And so, as I mentioned, the dryness and flakiness, loss of collagen, and then we may also see changes with acne due to our hormonal changes as well. Oh, sorry. Anyway, so this is just another illustration of the same slide, of the same concept. So then there are also environmental factors that will affect us, and the two primary things are smoking and sun damage. And this is a really well-known photograph that was in the New England Journal of Medicine, and it's a truck driver. And you can see the side of his face that faces the sun when he's driving his truck looks awful, whereas the side of his face that was relatively protected from the sun is not so bad. So when do you begin taking care of your skin so you can prevent these changes? I'm going to tell you to do it today. If you wait until you start to see those changes, it's almost too late. You're behind the 8 ball. And your foundations should be cleansing, a retinol product, antioxidants, moisturizing, and sunscreen. Those are your key things that if you start in your 20s, when you're in your 50s, 60s, 70s, and 80s, you're going to look better. Because frankly, I believe if you do all of this stuff, sometimes you may find you don't need surgery. So everybody knows I'm a proponent of medical grade skincare, and I'm just going to throw it in that it's stronger, better quality ingredients, has gone through the FDA approval process, has deeper penetration, and that's my plug for it. But I also realize it's very expensive, and some people can't afford it or don't want to spend that kind of money. So, as I said, the fundamental things are going to be a cleanser, vitamin C, and I think a retinol product of some sort is key for helping your facial skin. And when I talk about retinol products with my patients, a lot of them are like, well, I can't tolerate it. So, first of all, what is retinol? It's a vitamin A derivative, and what it does is it increases cell turnover, and it increases collagen production. Those are the two primary things that we like it for. And so that also improves healing and improves the quality of your skin as well as texture. There are different formulations. Tretinoin is the most concentrated and less well tolerated. Some of the retinols are better tolerated because it's the alcohol formulation. And what we refer to as retinoid dermatitis is some of the things that people talk about, the redness, the dry skin, the peeling, the sun sensitivity. And so the best way to start a retinol product is start slowly. I say start with the lowest dose possible and just start 3 times a week and see how your skin can tolerate it. Then once you've done the retinol, the other key component, in my opinion, is sunblock. Sun damage is awful for your skin. I am a big proponent of mineral-based sunblocks, which are titanium dioxide or zinc oxide. These need to be applied frequently, every 2 to 3 hours. Some of the sunscreens that we get in the drugstore are not mineral-based, and that's where people start talking about the toxic ingredients and whatnot in the sunscreen. I mean, the bottom line is something is better than nothing, but my recommendation is typically a mineral-based sunblock. When you're buying these things, you know, everybody goes to Amazon. You can even get Zeo skin products on Amazon. Just buyer beware. It's not always the same quality. There's counterfeit goods, and sometimes there's expired goods or products that are no longer available. So if that's where you're going to buy things, just buyer beware. So daily skincare routine, it's cleanser, alcohol-free based toner, alpha hydroxy acids, vitamin C, and sunblock. Then in the evening, cleanse. You can do your retinol then, and then a hydrator. So those are the big things that I would say as your daily skin routine. And then after you do all of that, you can start to consider some aesthetic treatments. Most of the common ones are things like toxins. There are multiple toxins on the market. What they do is they decrease the wrinkles caused by activation. So that's raising your forehead, frowning, your crow's feet when you smile, those kinds of things. There is some good, you know, you can start in your 30s and then those deep wrinkles don't get ironed in. I say, when you've got the wrinkles that they've been around for so long, it's like when you take your coat to the dry cleaners or your pants, and that wrinkle, you just can't, no matter how you straighten it out, you can't get rid of it. So the toxins help to kind of decrease that from developing, which is why I do think it's not a bad idea to start when you're younger, before those wrinkles have become ironed into your face, so to speak. Other aesthetic treatments are fillers. Once we're in our 30s, our facial fat compartments start to atrophy, specifically our deep facial fat compartments. And that contributes to that sagging that we also perceive in our faces as we age. And that's where things like fillers and fat grafting come in. And I'm going to be honest and say, you don't have to be overfilled. You just want to look refreshed. And then the other component that I truly believe in is also skin tightening. As I mentioned, we lose collagen drastically as we age, and so skin tightening treatments do have a role because they help to stimulate collagen. And so starting those before you've lost all the collagen in your skin is also a key component to aging with intention. We talked about eating and weight maintenance, that's key. Enough said. Drink water, also key for aging and maintenance. And then strength training, everything that you've heard before already. Dr. Singhal talked about a little bit about the GLP-1s. In addition to the loss of volume and the rapid weight loss that we see in our face, it does affect your skin elasticity. Your skin texture is different. So what that means is when we're treating individuals who are on GLP-1s, it's a multimodality approach, including tightening as well as surgical options. And so on the horizon, I just wanted to make a quick mention what's coming up. There's lots of talk about fat grafting. Nanofat is fat we take from your cells, your body, via liposuction and process it. And there's a lot of talk about that having regenerative potential. There's also some types, instead of fillers, there's fat injections that we get from cadavers that we can also do now, that's now FDA approved. There's new types of breast implants, and then, as I mentioned, regenerative things. Here's my skincare prescription for you. In your 20s, you start your daily skincare routine. In your 30s, you continue with that, and then start doing skin tightening and some aesthetic treatments. Continue with that in your 40s, and it's in your 40s and 50s that you may start to consider surgical options. And so, in my opinion, aging intentionally requires a holistic approach, including your mental well-being, which we're also talking about today, hormonal issues, which we're also talking about today in terms of menopause and perimenopause, and then your aesthetic treatments. And then when you do consider surgery, don't forget your skin. And remember that surgery is going to address very specific contour irregularities, and it's going to improve who you are, but it's not going to change who you are. And that's the whole goal of aging intentionally. And then choose your surgeon wisely, ensure that they're board certified, and know what they're doing, I guess. Because, people will come to me because they'll look on the internet and say, well, do you do smart lipo? Do you do this? And I tell people, it doesn't matter what the technique is, what the machine is, what the tool is. It's your surgeon who matters. It's the person who's using those tools. And so really pay attention to that. And thank you.
Dr. Bajaj, will you put up your picture of the skincare routine again? You had a morning and night. Okay. You guys can take a picture of it. I saw lots of people trying to. There was one that had a morning and night skincare routine. There you go. Take a picture. I would like to introduce Natasha. So she's a licensed family therapist.
Oh, wow, I got woos.
Right, you got woos. So she's a licensed family therapist. She's been practicing since 2008, and she recently got her doctorate in psychology, clinical psychology, and she does a lot of sex and relationship therapy. So she offices here at the breast center, and we left her cards and information. And so we're happy to have you. Thank you for coming today.
Thank you, guys. Okay, let's get this set up. Oh, perfect. Hi, everyone. I'm Dr. Natasha Langham, and I am a licensed marriage and family therapist. Like Dr. Taylor said, I've been practicing since 2008 and now specialize in relationship and sex therapy. I work with individuals and couples talking about sexuality and their sex lives, talking about communication, dysfunction, pain, pleasure. Sex therapy is a specialized form of talk therapy, and I believe that sexual well-being is vital. And I'm passionate about empowering women so that they can use their voice. I'm really, really happy to be here with such powerful women, both on this stage and in this audience. Okay, so sex is not just physical, it's relational and psychological. These two stats are really interesting and I think very correlated. Over 50% of women say that they have received negative sexual messages growing up, that sex is shameful, or that sex is for men. I'm sure that if you think back on your childhood, your previous relationships, the relationships you've had with your parents, friends, that sometimes you've received some of those negative messages. And only 50% of women say that they are satisfied with their sexual relationship. So I think these things are correlated. Are women not able to experience pleasure and intimacy because some of these sexual messages? This image I like to use in therapy. Beliefs are not facts. They're stories that we've accepted as true. So these messages that we've received about sex, they become our belief systems when we grow up, and we take that into our relationships. And so can we change our belief systems? Yes, absolutely, and that's like what we do in therapy. We question these belief systems, and we kind of poke holes into these balloons and see if the balloons still stand up or if they come down. Are these things still real for us? Do we think that this would be true if it was someone else's life? Or is it just like a message that we've received from maybe our families, our culture, maybe religion, that's left some traumatic piece in our life, and that we've just accepted as true? My next slide is the positive piece. Let's talk about oxytocin. It is a powerful, natural, and often overlooked hormone. It is called the bonding hormone, and it plays a huge role in intimacy, connection, and sex. Well, what is oxytocin? It is a hormone and a neuropeptide produced in the hypothalamus and released by the pituitary gland. It's known as the love hormone or the cuddle hormone, and it is great for social bonding and emotional regulation, and also comes out during childbirth and lactation. We want to have more oxytocin. We want to have more of these great experiences, relationships, friendships, intimacy with partners. We want to have more oxytocin because then we'll have a happier and healthier life. It combats loneliness and depression and anxiety. It relaxes our nervous system. It makes us more resilient as humans. It's just great all around. So, anyone know when oxytocin is released? Let's just have a quick little test. You can just scream out. I know the answers are on the board, but you can just say it out loud because we want to practice saying, when is oxytocin released? Sex, yes. What? Laughter, yes. Cuddling, yes. And therapy, which I thought was really fun. So you can have an oxytocin release with your therapist. Without the sex. There's no sex in therapy. There's no sex in therapy. There is no sex in therapy. Let me clarify. Besides sex therapy, I also am a relationship therapist. And some of the most profound research is done by the Gottmans. John and Julie Gottman have over 4 decades of research on couples, and they do this research on live couples, and they videotape them and watch them. And so I wanted to share some of these tips with you today. It's not whether or not a couple fights. It is how they fight and repair after that's most important. So these ratios I thought are really, really important, and I thought if we can bring them up to date and you could take it home, that you can even have a better relationship today. This is the ratio of positive to negative interactions. During conflict, you want 5 positive interactions to every 1 negative interaction. And everyday interactions, it's 20 to 1. So this means for every sigh, every eye roll, every criticism, there should be at least 5 warm moments, like a gentle tone, a touch of the arm, a validating phrase, or humor. So you could take that home and try to focus on that and see, am I being kind? Am I being loving? Just think about it in this way. Relationships thrive in an emotional climate of kindness, appreciation, and connection. And you don't have to be perfect, but keep the balance towards love. And that is it. I just wanted to give you guys a few tips today. And if you have any questions, thank you. And my office is just down the hall. If you want to come see it later, you can.
Did everybody take a picture of her slide so you could send it to your husbands, your significant others?
I'll go back.
Oh, that's where that slide needs to go.
There
There you
you
go. There you go. Try again.
Recommendations for how to advocate for ourselves when it comes to hormone replacement therapy and treatment of perimenopause and symptoms. And I ask this very specifically because I have talked to both my GP and my GYN, and every time I've tried, they've said, oh, you don't need to worry about that for a while yet, and yet I'm experiencing symptoms. So it's funny, Dr. Enix and I just talked about this earlier, that there 20 years ago, there was a Women's Health Initiative large study that came out that I think really made a lot of us as providers nervous about the risks with hormone replacement therapy. And I think that has shifted a lot over the last 5 years, 10 years, that we're less scared about it, and I think it's more about helping women feel better and not miserable through that transition. And so without, throwing anybody under the bus, maybe you need a new person that will listen to you better.
I have a question for Dr. Wiley as well. I had read somewhere that hot flashes cause essentially wear and tear on your heart. Can you elaborate on that?
We know that menopause has an effect on our cardiovascular health. And again, back to the initial Women's Health Initiative, there was a lot of that fear came from HRT is going to be harmful for us from a cardiovascular standpoint. But really, we know that there is probably some protective benefit there as well. So, yes.
I'll come over there next.
Hi, so I have a question. In regards to collagen, you talked about how our collagen decreases after a certain age. Are collagen supplements actually worth it, or is that just like a money-making scheme?
They don't work. But if you feel good taking them, I don't believe that they're harmful. There are lots of things like skin tightening, increasing collagen, all those things are like the holy grail in anti-aging, if you will, and we try a lot of different things and not everything works effectively. So I don't think the collagen supplements make a difference, but if it makes you feel better, then go for it.
There were a couple on this side, but I was a little nervous to walk back over here.
This is for Dr. Bajaj. I have tried many retinols, and I break out like crazy. So what would you suggest for a beginner to start with?
It depends on what you've tried before, and not knowing that, it's hard for me to tell you, but typically what I start with would be the 0.025% in just 3 days a week at night, but then sandwiching it with a hydrator and a moisturizer to help with that. But is it the flakiness that's causing the problems, the redness?
I will break out in it's acne.
Ah. I haven't experienced that before, but are you cleansing and so?
I have very specific scans, and I'm very particular about what I use. I do cleanse.
Okay. Have you tried other things that also increase collagen, like vitamin C? The activated vitamin C may be a good option.
I have, but not in a while. So
Maybe start with that and then go from there. And you can do anything from 10 to 30% and try that to start with.
Do you have a favorite vitamin C recommendation?
I'm still trying to figure out my favorite. We have the Zeo in our office, and I'm trying out the revision skincare, which is 30% right now. So I'll let you know. I'll figure it out when I find my favorite. I'm also, I mean, to be honest, I'm also experimenting. While I say that you need to start this in your 30s, I haven't always practiced what I preached.
Thank you for your honesty. We're going to do one more question here.
I just have a question about supplements for weight loss. Are there anything over the counter for weight loss at all, like ashwagandha or something like that?
Sorry, was that you, Diana?
Yes.
Okay. Can you talk to me, say it a little louder? You said the weight loss supplement specifically. I couldn't hear you well.
Ashwagandha.
So ashwagandha, you know, again, that falls under complementary CAM, complementary and alternative medicine, which we do have some studies, but limited studies. But ashwagandha overall does help. It kind of works like an insoluble fiber, if you will. Again, that concept of early satiety. So that's how it really can help promote early satiety, decrease intake, and weight loss that way.
Okay, I lied. One more. You raise your hand every time. You're good.
So about the GLP-1s, I just had a question about berberine.
About what? Sorry.
Berberine.
I'll turn it off.
Sorry.
Berberry. I've never heard berberry.
Burberry?
Yeah.
As
something you can use as weight loss, and also something about it's good for your gut health. But like, what's the truth about it?
So the fact that I haven't heard about it is probably, I really don't know.
So it's this thing on Instagram. I see the ads all the time. It's your GLP-1 by now. And it's important that, like Dr. Singhal brought it up, there is one FDA approved, and it's because of the chemistry of how we absorb these hormones.
That's right.
And so it is the only FDA approved.
Yes, I mean, in GI space in obesity medicine, there is no evidence for that particular. But again, we are living in such a consumer world right now, unfortunately, and we know Ozempic works and GLP works, GLP-1 works. So if you just attach that name to a lot of things, you know, people will get the clicks, the clickbait, unfortunately. But in terms of scientific world, I don't believe that's beyond, it's not something I've heard, and I just lectured nationally on it. So maybe I'm happy.
Well, and I would say just in the space of supplements in general, like we all talked about supplements that, you know, there's a lot of things that fit into a category of maybe it doesn't hurt anything, but it may not help anything either. And I think the thing to know about supplements is they can promise whatever they want. They can claim whatever they want. They don't have to have studies to back it. And if they say they do have studies, sometimes they're studies that they paid for themselves. And so a lot of times those things are about money again, and they can say what they want, they can claim what they want. They may or may not be helpful. They may or may not be harmful. So I think you have to be very, very careful about all things supplement, because a lot of times they are money driven.
Yeah. And I just looked it up. It seems like it originates as a bioactive compound from China in Ayurvedic medicine. Who was asking me that? So there may be some benefit. I really like the plant-based stuff. I don't think it can harm you, but be very, very and cautious of why you're purchasing it. Again, I'm all about holistic and natural incorporation, like turmeric right now. There are turmeric capsules. We know it's anti-inflammatory, but why can't we just incorporate it in food? Because the bioavailability and gut absorption is going to be 1,000 times better than when you take it in a pill form. So it's just, I mean, I do think there's some good value to that compound, just quickly reading, but will it lead to weight loss? No, that's a clickbait. Yeah.
I think just to reiterate, there's a huge social media industry, and you have to remember that everything you read on social media, it's not vetted. From a medical standpoint, we all believe in randomized, peer-reviewed, research and journals for publications, not just something that you randomly put up on social media. And I see it so often every day that just because it's on Instagram or TikTok, people believe that it's fact. And that's just not true. So buyer beware that what you see on the internet has not been vetted. It's just something somebody put up there.
Okay, we're going to draw one more name, do our gift for this section, and then we'll take a 10-minute break and let you get some.
So our first speaker, our next speaker is Dr. Arielle Allen. She's a board-certified urogynecologist, and she specializes in pelvic floor disorders, and so we're super happy to have her talk with us for a little bit. So this whole session now is going to be about pelvic floor, vaginal care, anal rectal care, the whole bit.
All right. Can everybody hear me? Okay. Yep. Just like Dr. Taylor said, I'm Dr. Allen, Dr. Arielle Allen. I'm a urogynecologist, which means I specialize in pelvic floor disorders. My topic today that I'm going to be talking about is pelvic organ prolapse, which is one of the more common pelvic floor disorders that I see in my practice. So here we go. So what is pelvic organ prolapse? Pelvic organ prolapse is when one of the pelvic organs actually falls into the vagina, okay? There are 3 main organs that can fall into the vagina: the bladder, the uterus, or the rectum, okay? I see all 3 in my practice. Sometimes women only have one of those things falling, some have 2, and some have all 3. The whole point of an exam in my office is to determine what type of prolapse someone has. All right, so on this slide, I have a diagram of what anterior compartment prolapse looks like, which is also called a cystocele. If you've ever heard the term cystocele, that means a fallen bladder. The bladder is falling into the vagina. It can fall into the vagina, and it can also protrude out of the vaginal opening, okay? So one of the most common symptoms of anterior compartment prolapse is the feeling of a bulge at the opening of the vagina. And so as you can see in this diagram, you can see the white arrow kind of pointing down at the base of the bladder. The bladder's falling into the vagina, okay? Another type of prolapse that's fairly common is posterior compartment prolapse. This is where the rectum falls into the vagina. You can see the white arrow in this diagram is in the rectum. It's pushing and falling down into the vaginal compartment, and it can also protrude out of the vaginal opening. And then there's apical compartment prolapse, which is the 3rd type of prolapse. It's the least common type of prolapse that I see, but I do see it. The 2 types of apical compartment prolapse: uterine or vaginal vault. Uterine prolapse is just what it sounds like. The uterus is falling down into the vagina, and it can protrude out of the vaginal opening. The vaginal vault prolapse occurs when a woman has had a hysterectomy, so the topmost part of her vagina, where the cervix and uterus were, falls down into the vagina or bulges out of the vaginal opening. That's called vaginal vault prolapse. So what are the risk factors, or who gets pelvic organ prolapse? Well, if you're a woman, you're at risk, basically. It's very, very common. Most studies show that about 50% of all women will get prolapse of some kind, okay? So it's very, very common. I see it a lot. Don't think you're alone if you have these symptoms, because you're not. But the risk factors are childbirth, having babies. That's our biggest risk factor. One of the biggest studies that was done looking at the risk of childbirth and development of pelvic organ prolapse later in life demonstrated that if a woman has had 2 vaginal births, just 2 babies, regardless of how big the babies were, regardless of how difficult the deliveries were, how long the labor was, whether forceps were used, whether vacuum, just 2 babies vaginally puts a woman at 8 times more risk of having prolapse. Just 2 babies. Yep. Aging, of course, 50% women over the age of 50 will have prolapse at some point in life. And so it's super common. Going along with aging is the hypoestrogenic status. As we go through menopause, our estrogen levels decrease, which you guys have heard a lot today. Having low estrogen levels increases a woman's risk for getting prolapse or having prolapse, okay? It's been shown that a decrease in estrogen decreases the collagen levels in the pelvic floor support, which decreases the pelvic floor strength, which increases the risk due to gravity of organs falling into the vagina. There's also family history. I tell patients all day long, if your mom, if your grandmother, if your aunt, if your sister has prolapse, you're probably going to get it too. It's so common. Chronic cough, chronic constipation, chronic heavy lifting, things like that. Things that put chronic repetitive strain or pressure against the pelvic floor increases a woman's risk of developing prolapse. And then obviously a collagen or connective tissue disorder such as Ehlers-Danlos or Marfan's. There are certain disease states that have decreased or weakened collagen levels, and that puts a woman at risk of developing prolapse. So what are the symptoms of prolapse? How do you know if you have it? These are the most common symptoms: vaginal pressure or feeling of pressure in the vagina, a bulge or something protruding out of the opening of the vagina. That's by far the most common one. A pulling or a heavy feeling in the pelvis, feeling like you're sitting on a ball. I'll have patients say, it feels like there's a golf ball there when I go to sit down. Difficulty with urinating or defecating. So if you feel like you're having a hard time emptying your bladder or bowels, that could be a symptom of prolapse. And then recurrent bladder infections. I see that frequently too. Although women are, unfortunately, the way we're built, we're all at risk for getting urinary tract infections, but having a fallen bladder increases your risk of getting urinary tract infections even more. Interestingly, and because there's a lot of misinformation out there about prolapse, pain is not a symptom of prolapse. Prolapse, as weird as it sounds, it is actually not painful at all. It's a weird feeling. It may be uncomfortable at times, but it's not painful, okay? So if you have pelvic pain, it's something else most likely. It's not prolapse. There are a lot of treatment options for prolapse, okay? There's non-surgical and surgical. I'm not going to go into all the details because I don't have time to do that. But some of the non-surgical options that I talk to patients about every day: expectant management. If your prolapse is not really bothersome to you, you don't, and this is going to sound weird, but you don't have to do anything about it. If it's not bothering you, if it's not really affecting your emptying ability, we don't have to do something about it. But if it does bother you, there's a lot of options. A great non-surgical treatment option is pelvic floor physical therapy, which somebody here is going to talk about here in just a bit. I send patients to Sherry all the time. She will talk to you about the benefits of pelvic floor physical therapy. It is amazing how much improvement a woman can get in their prolapse symptoms with just physical therapy. Pessaries, I don't know if anybody has ever heard of a pessary. A pessary is a great non-surgical option. A pessary they're mostly made out of silicone. There are devices that come in all sorts of different shapes and sizes that we would fit patients for in the office. It's a device you wear in the vagina. I describe it like a funny-shaped tampon. But it is worn in the vagina, and when it's inserted in there, if it's doing its job, it's going to hold the prolapse up where it belongs, so the patient doesn't have the symptoms anymore. Pessaries are very safe. They're very effective. They're not supposed to be painful. If they're painful, then they're not fitted correctly, and they don't increase the risk of infection, okay? Of course, there are surgical options for prolapse as well, which is also something I talk to patients about all day long. There are abdominal approach surgeries, so surgeries I do with incisions on the abdomen, and then there's vaginal approach surgeries where everything is done vaginally. Sometimes mesh is used, not very often. Sometimes it has to be. It's not the bad mesh though. All of the bad mesh products have been taken off the market, just so y'all know. But sometimes mesh has to be used to provide appropriate support. But most of the time, mesh is not used. Mesh is not appropriate for most types of prolapse. But of course, I talk about the risks and benefits of everything in the office. Sometimes we use biologic grafts that do dissolve, but it augment the strength of the pelvic floor support. Sometimes hysterectomies are performed at the same time, sometimes not. There's risks and benefits with that too, which I also talk about. Basically, the take-home points are: you might have prolapse. If you feel a bulge at the opening of the vagina, you feel vaginal pressure, especially with lifting or straining. You have difficulty, oh my gosh, I'm so good with my timing. I'm so proud of myself, that's amazing. You have difficulty emptying your bladder or bowels. Treatment options include several non-surgical and surgical options. And the surgical options nowadays, the success rates are so much better than they used to be. So if you've heard, there's misinformation out there about, the surgeries don't work or they fail within a couple of years. That's actually not true anymore. It may have been in the past, but we have newer, better surgical techniques now that are based on research, evidence-based surgeries. So high success rates nowadays. And then, something interesting, also a take-home point, urinary incontinence in itself is not a symptom of prolapse. Sometimes women have both, incontinence and prolapse, but incontinence in itself does not mean you have a fallen bladder, okay?
I am a physical therapist. My name is Sherry Bowes. I own my own clinic. I'm going to tell you where it's at. It's Yukon Wound Care and Rehab. Sorry, I'm not going to use any of the slideshows. But we're located in Yukon, and you're going to have one of these in your bags. It's going to tell you a lot of things that we do at our clinic. One is wound care, obviously. But I also specialize in women's health. I've been treating women since 1996. And anyway, what I'm going to focus today on is incontinence. Incontinence, stress incontinence, about 80% of women fit in that category. So there's also urge incontinence and there's mixed incontinence. But we're going to focus on stress, because that's the main one. In my office, what I do is I do an initial exam, and what I'm looking for during the initial exam is I'm looking for prolapses, but my main point is I'm looking for strength. If you can identify and use your pelvic floor appropriately. And so it's kind of funny, you'd think everybody would be aware of their pelvic floor, but many, many, many are not. So I'm just going to ask the audience real quick if you just put your hand on your belly, and then what I want you to do is do a Kegel exercise, if you know what a Kegel exercise is. And so if you felt your abdominal muscles, or if you took in a deep breath, you did not do it correctly. Because you should not feel either one of those if you're just doing the pelvic floor. So the pelvic floor is a hammock of 4 muscles that hold the vagina, the urethra, and the rectum in place. And so when we don't have strength or awareness of those muscles to hold them up, then our bladder leaks through the urethra, and then it comes out. So that's what stress incontinence is. Well, once I identify if your muscles are either really, really weak, or maybe you don't know they're there at all, that will tell me where to go with my modalities. So I have here it is. This is a vaginal probe, and this vaginal probe has electrodes on it. So it's placed vaginally. Once I know what your strength is, if you have no strength, I use electrical stimulation to jumpstart those muscles. I can also use it if you have urge incontinence, and that's for an overactive bladder, but we're going to focus on stress. And so once we get your muscles strong enough using this, then I'll go to a biofeedback. And biofeedback, this hooks up to the same one, and I get to set the parameters and the threshold, and your job is to work above the threshold, and so we make it harder and harder and harder. The next thing is, which is really cool, I introduce this to you, and that's when you do your exercises at home. These are vaginal weights, and I'm going to send these around and let you guys just feel them. Vaginal weights are placed vaginally that have various different ounces, and you place them in, and you go about doing your makeup routine, your bathroom routine, and your job is to hold these in, and that strengthens your pelvic floor. Once you can hold them in and they're not falling out, then you walk around the house. You do your dishes, you do your things that you do. And 10-15 minutes in your exercise routine, and you're done. But what that does is it really tones the pelvic floor so that you can laugh, cough, sneeze, run, jump, hike, all those things that you want to do with your kids without leaking. So I'm going to pass these around and let you guys feel them because they're really pretty cool. But the 3 takeaways that I want you to really get from me is 1, vaginal weights for home. Number 2 is something I don't think probably anybody in this room's ever heard of, unless you were here last year, and that is quick flicks. Did you know that you can do quick flicks of your pelvic floor that will tell your bladder, stop contracting, because I don't have a bathroom. I don't have a bathroom. I'm in my car, and it's in the house. So if you'll do a couple of those, even 4 a.m. in the morning, you wake up, and my 5 o'clock alarm is 5, not 4, but sometimes your bladder says, you gotta get up and go to the bathroom. Do quick flicks, and you can go back to sleep. Yeah, what? I know. Why didn't anybody tell me this? But really, if you'll do those, even just to get, from your garage to your bathroom, it'll help. So that's number 2. Number 3 is intercourse is vital to your pelvic floor health. And there's, because God knew that it was. So he told us, that it was, but it is really vital. If you think about it, intercourse pushes your prolapses back where they're supposed to be, not where they fall. And it builds pelvic floor strength, okay? So I always tell everybody, have intercourse as long as you possibly can. It is valuable to your relationship, but also valuable to your pelvic floor. So that's my lecture, but I'm going to pass this around, let you guys look at them. They've never been used. So you can also buy these on Amazon. So, but I'm just going to, and they're mine, I want them back. Pass these around. Again, this gives you a lot of information about what our company does, because we do a lot of different things. We're an independent clinic, and that's it. Thank you.
All right, I'm Dr. Jessica Enix. This is the last presentation. We stayed relatively on time, but we kind of planned it this way. This is the bookend to the end of the symposium. I am talking about the pelvic floor health, specifically perianal health, because it gets ignored all the time. But the pelvic floor is our foundation, the foundation to our strong cores, the foundation to the strength that is pregnancy and giving life. And we ask it to do a lot. So we're going to talk about it a little bit. So the thing that I really want to focus on is destigmatizing the discussion with your doctor about what's going on with your bottom. There's not a whole lot of things that create a lot of healthcare risks and problems, but perianal problems really affect your quality of life. And if we're ignoring them and we're not comfortable talking about them, I want that to stop. I want us to be able to walk into our doctor's office and complain about our hemorrhoids or complain about discomfort when we're sitting on the toilet. So we talked about this anatomy. Men will likely also benefit from pelvic floor physical therapy, but their anatomy is very different. They have a rectum and an anus like we do, but they do not have a vagina. And we ask our bodies to grow babies, push them out through these strong muscles, and it's something that a man will never have to experience. And so we have to think about our foundation differently. This is what happens. So even if you haven't had a vaginal delivery, just by nature of a pregnancy, it drastically changes the pressure on our pelvic floor. It strains those muscles. It can thin out those muscles because oftentimes we can't flex them appropriately while we're pregnant. It affects our bladder because it's crowded out. And then lastly, the pressure on our bottoms, hemorrhoids. So even without a vaginal delivery, the most common cause of hemorrhoids in women is pregnancy. This is a picture of those muscles that Sherry was talking about. This right here is a straight, strong muscle in men. In women, we don't have that. This is where the babies come through. So it's very important that we keep in mind the changes to our bodies as we start to get older.
Every single one of these muscles responds to hormones. Their strength, their elasticity, their ability to bounce back, all responsive to estrogen. So as we become perimenopausal and go through menopause, these muscles will change. A lot of our doctors talked about vaginal dryness. That can be treated with estrogen. Well, you know what else happens? Our anus starts to get more dry, and that predisposes it to trauma. So anal fissures, painful bowel movements, bleeding with bowel movements. We can actually see improvement with this, with estrogen replacement if it is needed, and pelvic floor physical therapy. So this is just the anatomy of everything that our stool passes through. And the anal canal is actually really complicated. But this zone here is what I was talking about earlier, that we see that transition zone where we can start to get anal cancer. So we're going to be talking about hemorrhoids. These do nothing to create medical risk factors, but they impact our quality of life. We have both internals and externals. We have non-surgical treatments for them, which can be pelvic floor physical therapy, minimizing straining, minimizing time on the toilet, making soft, easy to pass bowel movements. Now, I like to talk about hemorrhoids and fissures at the same time, because hemorrhoids itch and burn, they're uncomfortable, fire-breathing dragon, can cause some mucousy discharge, but they do not feel like razor blades coming out of the bottom. So if you've ever walked into your doctor's office and you were like, I was crying on the toilet with my bowel movement, and they told you you had hemorrhoids and they gave you hemorrhoid cream, that is the wrong answer. That is an anal fissure, and we need to treat it differently. So this is just a little recap on the healthy GI function, the importance of fiber, promotes soft, easy to pass bowel movements. Magnesium, it got brought up in one of our other talks. We get all kinds of benefits from it. Healthy GI activity, great for muscle strengths and spasms, helps with calmness and sleep at night. Stool softeners, we use them as needed, right? We don't want to be straining. Cathartics, if you are using these regularly, you have got to talk to your doctor about it. We want to stay away from these, if at all possible, because our bodies can become dependent on them. If we're using them regularly, eventually the intestines just stop contracting. And then we talked about probiotics. So, this is the big thing about the toileting habits, okay? So when you sit down on your toilet, all the pressure that you are generating in your body is going right through that stool lid. And so we want to spend minimal time on it. Don't have your book in there, don't have your phone in there. It is only for business. I already talked about the bidet and the wet wipes. And then squatty potty. Dr. Singhal talked about that already, but it's important because it changes the angle of the bowel movement. So, right here, you're sitting, and we end up with an angle like this. If we bring those legs up like this, it straightens out that rectum and allows for an easier to pass bowel movement. So medical treatments, we talked about all of these: bidets, minimal time on the seat, sitz baths, which is just a warm bath, pelvic floor physical therapy, and then hemorrhoid cream. Now, here's the big one. That was supposed to go over hemorrhoid cream. But if you have an anal fissure, do not use hemorrhoid cream. Hemorrhoid cream has a steroid in it, decreases inflammation, decreases skin healing. Hemorrhoid cream has a vasoconstrictor in it, which is great for very swollen hemorrhoids, but it keeps your body from healing. So if we put hemorrhoid cream on an acute anal fissure, we make it chronic. So I like to bring this up because I see a lot of anal fissures. There are lots of options for treatment. I do a prescription strength nifedipine cream. That's what we start with. I also do Botox injections. The last resort is surgery. Surgery actually involves me cutting the anal sphincter in half. And so there is no way that any surgeon can say, you know what, you'll have zero risk of stool incontinence. So it's very, very serious whenever I see these women. I always tell them, you know what, we're gonna treat your anal fissure, your hemorrhoids might get a little worse, but I can treat your hemorrhoids surgically and I don't have to give you a risk of lifetime stool incontinence. So surgery is sometimes required, but I try to prevent it at all costs. So this is what it looks like. Scalpel goes up. We have two sphincter muscles, goes right through the internal sphincter, which is a circle, and then I make it do that. So if you can imagine, it has plenty of risks. Now, for hemorrhoid treatment, there's lots of surgical options. We have rubber band ligation. This is hemorrhoid light. Does not get rid of the hemorrhoids, but makes them smaller. The thing that's nice about this is we can do it on a Friday, but by Monday, you're feeling great. I will say most of my women do decide to do this in the operating room, but we can do this in clinic with a motivated patient, a little treatment for anxiety, and lots of numbing medicine. So we have a little bander here, and I hope this doesn't scare anyone, but it's a pretty straightforward procedure. Lots of cream, lots of lubrication. So this happens, and then I simply just take this, grab that little tiny internal hemorrhoid, and then the band is right here on the end and just slips over the top. So everything from here will be requiring general anesthesia. This is a type of treatment that removes the internal hemorrhoids only. I offer it because it is much less painful than traditional internal and external hemorrhoidectomy. If we treat the hemorrhoids, which is where the blood vessel starts, that starts this whole process, oftentimes we can see decreased flares of the externals. This type of procedure, you have pain for about 5 to 7 days after surgery. And then this is our traditional internal and external hemorrhoidectomy. This allows me to remove everything, but this is a mental game. We have to be in the position that we are ready to recover from it. The first 2 weeks are very difficult, but pain control is approached from every way that I can possibly think of. But this will treat and get rid of both internal and externals. All right, and that's it.
This session is always one of our favorites because it's something that people just don't talk about, and you three do excellent at things we always have questions about. So we'll take a few more questions if anybody has questions for them. Yes?
Is there any alternative to hormone replacement therapy if you can't take hormone replacement therapy and have the hormone blocker?
So, the area that this can be a little bit difficult is in patients that have risk factors or a personal history of breast cancer that's hormone responsive. The thing that is very interesting about this, there are options. We can do things like Riplens and non-hormonal replacements, pelvic floor physical therapy. But even if we're just using a topical, local, regional estrogen, it does not increase the estrogen floating around in your bloodstream. Now, that is a very personal decision, especially when we're post-treatment for, I just keep thinking of breast cancer. And so it's very personal. We can exhaust every option on the table before approaching a hormone cream, but a hormone cream is very safe. And I can't tell you how many gynecologists think that every postmenopausal woman, whether she's on HRT or not, should be having vaginal estrogen.
Well, that's a really good question. There's actually several things that you can do, and it really depends on, there's a lot of different kinds of vaginal pain. So I'm gonna basically just go with like a vaginismus or really tight or stenotic vaginal opening or pain up in the vagina, I can use the electrical stimulation as a treatment that will help desensitize sensitive tissue. I can use biofeedback in a reverse way. Instead of strengthening, you're relaxing. We also use vaginal dilators to help maybe just widen the area. If it's been really tight, maybe from a surgical standpoint or maybe a trauma. So there's a lot of different things that cause pelvic pain, but that's generally how you treat it. Sometimes it's an open wound that you don't even know you have. So I do have to investigate the area to find out exactly what's causing the pain.
Another question? I thought there was some back here. Oh, here we go. I'm going to hand you the microphone.
For Dr. Allen, I have a friend who has, I think, the anterior prolapse with both the bladder and the vagina or uterus coming through, and she's been told that the surgery really causes an 80 to 85% incontinence, and that seemed a little extreme to me, so I just wanted to ask that.
The surgery for prolapse is not going to cause incontinence, but if someone has some form of dysfunction with their bladder that leads to incontinence, prolapse can mask that. And so by fixing the prolapse, you can unmask that dysfunction that was already present. But I will say, any type of incontinence can be treated. Okay, so if you happen to unmask somebody's leakage, which a surgery isn't going to cause, but it can unmask incontinence, that incontinence can be treated. And at 85, I don't know where that number came from. That's not based on research. Yes. Oh, that's a great question. Now?
The question was, what age should you start doing Kegel exercises?
I am a huge believer in Kegel exercises. Sherry can speak to that as well, I'm sure. Kegels are a great way for women to keep their pelvic floor strong, which can help prevent prolapse and incontinence, or at least reduce someone's risk. I guess if I could pick the most important time would be during pregnancy and right after childbirth, if I had to pick one. But a woman should be doing them all the time anyway. Do at least 30 a day.
And something to add to that, I started to appreciate this as I was getting older and being a surgeon. I actually had to go to I went to the gym and I had to hire someone to show me how to do my personal trainer, yeah. So, I'm a doctor, I know muscles. I was having severe back pain. So the thing that I learned is this mind-muscle connection is really, really important. And if you're not using it and you're not mentally engaging that brain to contract those muscles, you forget about it. And I was doing something, I was getting winged scapula, which is this weird musculoskeletal thing because I didn't have the connection. Now, we know that if you just start thinking, all right, I'm going to contract those pelvic floor muscles, that helps us maintain that connection and that strength.
Yeah, I mean, as a gastroenterologist, I will also add that what Dr. Allen just talked about, organ prolapse, it's been very humbling for me from a GI perspective to realize that being a female is just a risk factor.
I'd like to answer your question too. The youngest patient I've ever had as far as for incontinence has been 15. And she wasn't sexually active or anything, she just wasn't aware. So I just needed to teach her awareness. Once I taught her, she was great. My oldest patient has been 95, just trying to re-strengthen the pelvic floor. And I was going to add one more thing. Another takeaway from today, when you do your Kegel exercises, you need to do them functionally. So a lot of times, we don't think that way, and it should be lying, sitting, and standing. And we just don't, we usually feel it most when we're sitting, but we need to be able to do it in all positions all the time.
I have a quick question about when I'm right over here. When you're talking about the quick little flutters, is that just like really fast Kegels?
Yep.
Okay, I just wanted to make sure that I understood that correctly. So you just do a couple really fast ones and that'll help you?
Yeah, just do 3 or 4 really quick.
Okay, because I've heard horror stories from friends who have peed in their car seat because they couldn't get to their house quick enough. So that will just stop that?
Yep, and I swear it's gonna work. I'm telling you, when you wake up, when you wake up at 4 in the morning,
yeah,
you're like, I don't want to do that because I got another hour, and I know if I get up, I'm not gonna go back to sleep. And so you have to control your bladder, and the muscle in the bladder is called the detrusor muscle. There's a muscle that sits down there. That's what tells you when and when not to go to the bathroom. And we as women, we kind of go to the bathroom too frequently. So then we get overactive bladder. So the quick flicks help you with the overactive bladder. It gives you the control, not your bladder.
I know.
I have a question for all of you since you're so, the expertise on our anatomy. But I will say the quick flicks, I learned that last year at this same symposium, and it has saved me so much laundry over the last year. Because it gave me back that control. Like I can decide when the bathroom, gives me back like 2 minutes if I need that 2 minutes to make it. Anyway, different times of the month I seem to experience pain during sex. Like, are my organs moving around? I don't understand why sometimes I feel like I'm being poked in all my other organs, and other times there's plenty of room. And I'm just like, yeah, go to town, have fun. But other times I'm like, make this one fast. I'm gritting my teeth going, why are my things being poked?
That is the hormonal response to your pelvic floor. The pelvic floor responds to hormone fluctuations, increased blood flow, increased laxity of the pelvic organs. It's possible that you may have a little bit of prolapse or weakening of the support, because those symptoms do worsen with fluctuations of hormones. So it could be, sorry.
Oh, go ahead.
And so I just kind of I wish I had that slide that Dr. Wiley put up, that perimenopause window. It's kind of like we are running at a full tank, and then we can wake up the next day and our tank could be empty. And it's really difficult to figure that out. And when we are going through any of these changes and these hormone fluctuations, we need to be able to communicate with our partner, right? So if it is happening, then increasing lubrication. If it's happening more frequently, then actually even starting with the potential for an estrogen replacement just vaginally, because it's really all of those fluctuations. Once we've hit menopause, we're at this nice steady state, and it's a little easier for us to treat and manipulate, but that fluctuation over time really can create some great intimacy experiences, and then can create some really not great ones.
I just had a quick answer that might help in your situation, in a lot of women's situations. When it comes to pain, sometimes during intercourse and other times it's fine. It may have some of that prolapse or moisturizing ability in the vagina. So if you'll do one thing, and it's on Amazon also, there's a real cheap set of dilators on there. And if you'll just use that just for a couple of minutes before intercourse, it's going to push things back where they're supposed to be so that maybe you won't have the episodes. Okay? Anyway, and they're really cheap. I think they're like $20.
Well, a few things. So first, I would like to thank all of our speakers today. Everybody put a lot of time and effort working on the slides and helping. I really appreciate that. There are several people, Dr. Bach, Dr. Bayless, Denise, Rochelle, Cole, that came in and helped and set up and got everything ready for us, so I really appreciate that. We had sponsors for food, Ambry Genetics, and we had sponsors just in multiple things. And what's the company's name? Establishment Labs. They do breast implants. They helped us. Thank you so much for coming and being a part of our event. If you can take the time to fill out your evaluation sheets, that really helps us know what to do differently next year. And I forgot to set out the cookies, so there's a bunch of cookies over there now too.
Is that correct? She TV. And they have a lot of podcasts that are free, accessible on women's health from all of us, actually. So please do visit their website. Good information.
Thank you all for coming.